Whether you're
I've never approached people.
Is this your phone, by the way?
Was that and the shit? Just jump in.
Designated.
We're looking at a house.
You are?
Gina, yeah, of the
So there's still a couple of people checking in. Just make sure you help yourself to coffee and pastries, and we'll get started in just a couple minutes. Yeah. Wait for. Megan.
Check, check. We're going to be getting started here in just a minute. So for those of us joining us online, we are letting people funnel in and we'll be starting shortly.
Oh, yeah.
Zach sent me a slide. Yeah. Zach, I don't see it. We'll probably move on without it. Huh? I don't see it yet, so we'll move on without it.
It's literally just 5 minutes.
Yeah.
I think that's fine. We can share.
Yeah. Oh, I put it down. You put it in. I see.
We're good.
All right.
I think we're good. Let's do it.
All right, perfect. All right, everybody, we're going to go ahead and get started here. We have a pretty packed agenda. We want to make sure we can get to everything. So first off, I just wanted to give an initial welcome. My name is Patrick Kinghorn, and I work in the OHSU Department of Dermatology. I'm sort of going to be acting kind of as just a host for housekeeping, and then I'm going to pass it on to Dr. Barry here for the actual event. So at a glance, what we're doing today, we're going to be hearing from a very, very wide panel of OHSU experts that work with melanoma. So we're super excited to be able to have them come up, share a quick little bit about who they are, what they do, and some of the work that they may be particularly excited about. And then after everyone does their capsule presentations, we're going to move into our meet and greet, which effectively will give you guys a chance to have a little bit more of an intimate conversation, ask your questions, hear a little bit more about what they do, sort of anything goes. We want to keep it kind of low key and fluid, and hope it can be a really fun and engaging conference for everybody. After our meet and greet session, we will also have an extra open question and answer session.
We want to hold questions until then.
Yeah. So we'll get there. Goals for the day. We really want to engage as a community. This is our first in-person melanoma event since COVID. So we are very excited to have everyone back in person, as well as the people that are joining us virtually. It's sort of a new era to be able to do both, and so we're super excited about that. We really want to have both of our in-person and virtual participants play an active role in our conversations. So we are going to have a pretty full agenda, but let's go ahead and keep your questions. If you have a burning question after the capsule presentation, you're welcome to raise your hands and we'll take quick questions. Otherwise, the meet and greet session and the open Q&A session will be the best time for your questions. In your folders that everyone has, you will see that there are note cards and a pen, and there's pens up front, and you have a notepad. So if you want to write your questions as you're going along, if you hear anything during the presentations, you're welcome to keep those for yourself. We also, if you don't want to say your question out loud, but you want to have your question answered, we have a little drop box right up here up front for any questions of that nature. For the people that are online, to ask questions or communicate to the speakers, you're going to use the Q&A tab on your Zoom window. We'll be reviewing all of these questions and we'll address as many as we can. And we especially encourage the dialogue during our meet and greet breakout session. If you're joining us through Facebook or YouTube, please put your questions in the comments and we will transfer them into Zoom for the panelists. And I believe that ends my piece. I'm going to hand it over to Dr. Berry.
Well, thank you guys so much for coming today. I mean, this is just such an incredible opportunity to be together. For those of you who don't know me, I'm Elizabeth Berry. I'm the director of our Pigmented Lesions Clinic, and I'm our lead dermatologist in our Melanoma Multidisciplinary Clinic. I'm playing second string quarterback today because Dr. Leachman unfortunately picked up something on the plane back from Italy where she was attending an international melanoma working group. So I talked to her last night and she is so sad that she can't be here, but she was so stuffy she could barely talk. So I'm going to try to channel her enthusiasm and really introduce you to this really, truly internationally wonderful group of speakers. So to kick off, Jake Nelson is going to be talking about the war on melanoma. Jake will be joining our dermatology residency the year after next and has done a tremendous amount of work in his research fellowship with us. So Jake, you want to come kick it off?
All right. Thank you everyone for being here. So I'm going to talk a little bit about the war on melanoma and some of the work that we did, kind of focusing on the campaign that we did last year. So can everybody hear me okay? Okay, great. So kind of the 50,000-foot view of the war on melanoma. It's a broad statewide education program that that aims to reduce mortality and cost of melanoma in the state of Oregon. And we do that by teaching people how to detect melanoma earlier. It was started by Dr. Leachman in 2013 and has involved thousands and thousands of person hours that went into planning and organizing education and curriculum and this campaign that we did. We also did a pilot campaign in 2019. And I'm going to kind of focus on, since I only have 5 minutes, I'm going to focus on this primary campaign that we did last year. So we targeted three main groups to try to increase early detection of melanoma. The first group is the general population of Oregon, which is about 4.2 million people. And I really want to show this video that Dr. Leachman created because I think it's really well done and really powerful. So I'm going to play it. Hopefully we have sound here.
Melanoma, the most deadly form of skin
Thank
cancer,
you everyone for being
has a
here.
99% survival rate when treated early, but that drops to 30% when caught late. Melanoma stands out. It's the cancer you can spot and stop with your own eyes. By checking your own skin, you could save your own life. So if you see a spot, talk to your doctor. Check your skin. You could spot cancer. Learn more at startseeingmelanoma.com.
All right. So let's see, where'd my other slide go? I lost a slide in there somewhere, but that video is what we use to target the general population and spread this message that if you catch melanoma early, you can save your own life and increase your odds of survival. So we created this huge campaign using billboards, mass media, TV ads, playing this
Talk
message,
to your doctor.
radio ads, and got a total of 101.2 million impressions, which is an astronomical number of impressions for a campaign like this. So we were very happy about that. And just to show you kind of where we were campaigning, this is a map of Oregon, of course. You can see the population density. About 75% of the population live kind of in this greater Portland area and then all along the I-5 corridor. So to show you where we played radio ads, these are all the radio stations that played ads, all the TV stations that played the ad, all the newspaper ads that we put out, all of the billboards, bus ads, transit ads, digital billboards. These are the high schools that we incorporated a curriculum, which you'll hear more about next here from our excellent group of medical students. Some grassroots outreach efforts like skin cancer screening events and health fairs. And here's our total of 101 million impressions. So using this model, we estimate that over 98% of the population of Oregon live within the area that we campaigned. So we feel pretty happy about, reaching everybody in Oregon. And I wish I had more time to go into more depth, but to kind of suffice it to say that we reached out to every skin-aware professional in the state, which includes estheticians, massage therapists, anybody who sees your skin while they're working with you. We provided educational material to them to kind of increase the odds of being able to catch a melanoma early. So these are the areas that we kind of engaged some of these professionals in throughout the state. And then likewise, we contacted every single primary care provider in the state as well to provide them resources and additional education to help catch melanoma early. So the whole idea is to try to shift as many people from that group of 30% survival over to the group that has 99% survival. And this, I just included these slides to show kind of an idea of just how many people were involved in this. It's absolutely mind-boggling to me how many people were involved in this and just how many hours and just how much effort was put into it. And so just wanted to share kind of that update, and I wish I had more time, so please ask questions if you have any questions. So thanks.
Thanks, Jake. I think that Jake sort of undersells himself. He was the one responsible for all of those really incredible graphics that show the overlap of the reach. And you can see that through this multifaceted campaign, we've really been able to reach the entire state, not only the entire state, but also the places that don't have dermatologists to start getting people to check their own skin. All right, well, next I've got two of our just outstanding rock star medical students, Gina Calco and Elena Paz Munoz. They're here to talk about the high school skin cancer curriculum and our underserved community outreach.
All right, hi, I'm Gina Calco. I am an MD PhD student at OHSU, and I'm going into my 4th year of medical school. And I'm here to talk about the Wanted Melanoma Education Campaign. I'm currently the lead of a group of students. These are medical students who designed a campaign to educate students across the state of Oregon on melanoma, skin cancer, and sun safety. So despite the high rate of melanoma in Oregon, there's no formal current statewide program in high schools that educates students on this disease. So we designed this curriculum using multimedia principles and proven learning theories to allow students to learn more about self-skin exams, when to see a healthcare provider, and promoting the discussion of individual and family risk. And so we did this through various games through the entire lesson. It's a 50-minute lesson, which is what most teachers asked for in the state of Oregon. They said, we don't have time for a super long lesson. Let's have something that we can fit into our schedules and that'll really work for us. And so we made that happen. And we encouraged including the family unit as a whole in this discussion, not just having the high school students themselves learn, but having activities and worksheets to take home and to sort of spread the knowledge out. So we used pre and post-test surveys in order to do this and to access and understand the efficacy of our curriculum. And so far, the program has reached 107 high schools across the state of Oregon, as well as over 12,000 students. And you can see in this map that I've provided, this is the reach of all the counties in Oregon that we've been able to get to, and it overlaps a lot with what Jake just showed about where we're trying to reach and how we're trying to get to the rural communities as well as the urban areas. So students who completed the curriculum significantly increased their knowledge about melanoma and risk factors. And they also increased their confidence in both checking their own skin, knowing when to contact a healthcare provider, and knowing and saying that they were more likely to wear sunscreen following completion of the curriculum, which is really something we're excited about and happy to hear. So the results really underscore these gaps in knowledge that were in the high school population in Oregon, and the shifts show some positive changes in behavior. So we're hoping that we can correlate what they learned in the classroom to real life changes in behavior. And we know that intervention early and intervention in adolescence is something that is proven to be effective, as they're going to learn this multiple times over their life and hopefully avoid some of those burning sunburns and different things that can add up their risk factors with sun exposure. So our ultimate goal is to establish this curriculum as a lasting part of the Oregon high school education system. And we're currently now excited about our new projects that we're rolling out with this. And those include doing a teach the teacher model, which is designed to teach college students to teach the high schoolers. And so they're going into classrooms in person now and teaching this to what are just very close in age to them peers, which I think is a great idea and are really going to get everyone active and involved from high school, college, medical school, and beyond. We also now have translated our curriculum into Spanish, and we're giving that as an additional accessibility option to students and their families who would like to have different languages, where some of our goals are to increase the number of languages that we have available for students and to plan to expand our reach across the rest of Oregon as much as we can.
Hi, everyone. My name is Elena Paz Munoz. I'm a second-year medical student here at OHSU. Before we start, I'm just going to show you all a quick clip so we're all on the same page.
Have you ever been screened or diagnosed with melanoma or skin cancer before?
No, I didn't think skin cancer would be a problem for me as I have darker skin.
On the forms you filled out, you indicated that you are Latino.
Yes.
It is a common belief that people who have darker skin are not at a risk for melanoma, which is one of the most serious types of skin cancers. According to the referral, your family doctor was concerned the spot on your hand might be melanoma.
How serious is it?
It can be very serious. That is why I'll be examining your hand and skin. What do you know about melanoma?
Very little. The first time I heard of melanoma is when my doctor told me I needed to get this spot checked right away.
So this video is part of our collaboration with Dr. Costello from Mayo Scottsdale. You're all getting a sneak preview of this video as it has not officially been released. So we would love to hear feedback from that standpoint. As soon as it is, we will start using it to continue educating our communities here across Oregon. So as you've heard, melanoma is less prevalent in skin of color, but when it occurs, it tends to be diagnosed at a later stage. As a result, the prognosis is worse. This is partly driven by lower public awareness of melanoma among individuals of color, and the false belief that they are at no risk for it. In skin of color, melanoma is most common in less sun-exposed areas. So this is the reason our group is focusing part of our outreach in skin of color populations. We seek to bring awareness, education, and skin cancer screenings to dermatologically underserved populations. At every event we go to, participants are shocked to learn that you can get melanoma on your foot, in your nail bed, in your eyes, and other places that are protected from the sun. So we educate them about where to look and what to look for. Within the last year, we have attended over 20 events in 7 counties across Oregon. To this day, we have offered approximately 300 skin cancer screenings and engaged with over 1,000 Oregonian families. We are very excited about this project and to keep moving it forward. So we would love to hear your input and if you have any ideas as to how we can expand and just further our outreach. Thank you.
Thank you, Gina and Elena. That was tremendous. I think this particular outreach is also really special because we're bringing knowledge to the high school students who are bringing knowledge to their parents, and it's just this way of disseminating knowledge about skin cancer throughout the community. And then also we're dovetailing, we're not bringing the same message to people with darker skin, right? Because their risk is different. And this is something I've thought about, and we've all thought about for a long time, that, one size fits all messaging doesn't work. And so I think this project is really, really special and is poised to bring a huge impact. Well, I'm gonna spend just a couple of minutes talking about a little bit about what I do. I wear several hats. I work in our multidisciplinary melanoma clinic. I run our high risk genetic predisposition clinic. But my workhorse kind of bread and butter is just doing skin checks and looking for melanomas and counseling people about sun protection. So I wanted to give you 3 things that I learned from a recent project we did with a bunch of textile engineers, where we compared how UV protective clothing compares to sunscreen. And it was really eye-opening. So the first point that I've found really amazing working with these engineers who are much stronger in physics than I am, is that shade is not enough, okay? So if you are in the shade, there's this thing that happens when light interacts with a solid surface called diffraction, and that light can actually bend a little bit around the solid surface. So if you're under an umbrella and you look like you're in the shade in visible light, the faster wavelengths of the ultraviolet radiation, which is moving a little bit faster at a shorter wavelength, or it's moving at a shorter wavelength than the visible light, actually bends a little bit further. So you can look like you're in the shade, but you're actually getting a dose of ultraviolet radiation. There's a lot of kind of scatter off the ground too. There's reflection of that harmful ultraviolet radiation. And we know that UV radiation is one of the most powerful carcinogens for developing melanoma. The second thing that I learned is that everybody's probably rubbing in SPF 30 sunscreen too much, okay? So, we preach that we love the mineral sunscreens, the zinc oxide based sunscreens, but gosh, they're chalky. And so when you get an SPF 30 sunscreen and you rub it in, when we actually looked at the way that people rub in sunscreen compared to the way that it's actually FDA approved, which is like twice the amount. You're supposed to use just an enormous amount of sunscreen to cover your body. The sunscreen at SPF 30 that people rub in, to try to get it to not be visible, actually lets in a significant proportion of harmful UV rays. And so that was really eye-opening. So SPF 50, probably not anything higher than that, but at least SPF 50. And then the third thing we found, obviously I was working with some textile engineers, was that all this sun protective clothing actually outperforms sunscreen. It makes sense, right? Because you've got something that you're not trying to rub in, that you're not trying to make invisible. The clothing actually blocks light across the entire ultraviolet spectrum and really, really protects, whereas sunscreen often lets in some of the harmful UVA rays that are closer to the visible light rays. And so those were the 3 kind of powerful things. Now, I'm not saying, use any one particular modality. I think you need all of the modalities. I think you need the sunscreen, the UV protective clothing, and the, shade-seeking behavior to really protect yourself from the ultraviolet rays. But I thought those were the 3 most eye-opening things from our study. And I'm happy to talk with you guys more about that when we break out into our expert groups. So hopefully that caught us up a little bit, Patrick. So we're going to move on to Zach Garrison, who is out of Raj Kulkarni's lab. So the Kulkarni lab does a lot of looking at how, you'll hear more from Zach about it, but the biggest research project they have is basically how immunotherapy reacts with the skin and induces different skin rashes. But Zach's going to give us the full update.
All right, can everyone hear me all right? Perfect. Well, it's a pleasure to be here today. Again, as Dr. Berry mentioned, I'm filling in for our PI, Raj Kulkarni, who unfortunately, like Dr. Berry, could not make it today because of illness. I'm really excited to talk to you about a couple of the projects that we're working on in our lab. As Dr. Berry mentioned, we have some really interesting immune therapy related response studies that we're working on, but I'm actually going to talk about A different study that we're working on that's really exciting has made a lot of big progress in the last couple of months, looking at a new drug that's actually being tailored for multiple sclerosis and how we can adapt it to use it to treat melanoma and offer it as a new therapeutic option. It's currently in clinical trials for multiple sclerosis, and based on some colleagues that we've been interacting with, we've realized that there is an opportunity for us to adapt that drug at a lower dose, and actually we found it to be quite effective in decreasing the rate of melanoma tumor growth. We've been working primarily in mouse models the last couple months with slightly different experimental parameters, and what we found is that the tumors grow in these mice of different melanoma cell lines pretty significantly less than what they would with no treatment or with sort of a control. And so we're really excited about what this data means for trying to adapt this drug for clinical use, what it means for clinicians to have another option to treat melanoma other than sort of the common therapies that are available today that have a host of variety of different side effects. I would love to show you the graphs, but I came in a little last minute, so I don't have the data. But we're really interested to see where the study goes and how we're hoping that in the next couple of years this might be an option for our patients to have a different treatment option. The next study that I'll talk about briefly is looking at circulating markers in the blood and how we're really excited about there are a variety of different markers that are coming up in research, both in our lab and a variety of different labs at OHSU and beyond, for detecting melanoma at early stages, as well as how we can use those markers to predict how patients will respond. So one of the most important things for melanoma as a whole is not only just can we identify it earlier, which is what a lot of the our great speakers have mentioned today, but also how can we better treat those patients once we've identified the melanoma. One thing that comes up a lot, as Dr. Berry mentioned a little bit, is the side effects. So inflammation is a big issue at a variety of different sites, and we want to learn how to better predict when patients will develop specific side effects, where they might be, and then how we can better treat them without having to change their course of therapy for melanoma. We have one specific marker that we've looked a lot at, which are circulating tumor cells, which are basically at the primary tumor site, the cell will break off, go into the blood, and then spread. And that's how you get distant metastases at different sites on the body. And so what we've looked at is how we can identify, pull out those cells from the blood, and then do different analysis on it so that we can learn interesting information, how we can better identify that specific melanoma and how we can potentially fight it differently. So a project that I've worked on specifically, and a handful of other members in the lab, is designing a new way to actually take it out of the blood. I've designed a new protocol that actually allows you to capture a much broader population of those cells. And it's actually really unique in that it's adaptable to other cancer types. So obviously, this conference is all about melanoma, but we're also interested in trying to create new methods for clinicians to better identify these very interesting cell populations for different cancers. So I've also worked on adapting this for prostate cancer as well. And then the last thing I'll mention is, kind of going off of that, the blood and the circulating markers, we're also sort of starting a new study looking at sort of similar patient populations being treated for melanoma and how we can identify other markers in the blood that might indicate how they might respond to those treatments that they might be starting at later stages of melanoma, and then as well as how we can predict side effects as well, beyond just the inflammation of maybe the skin, but also internal organs as well. So that's my spiel, and if you have any questions, I'll be happy to chat about it afterwards.
Thank you so much, Zach. I think that, adapting new drugs or old drugs for other purposes to treat melanoma is a very admirable goal. And then also the tracking of circulating tumor markers to see response to therapy and other things like that. It was really awesome. Had the privilege of watching Zach for the past, almost 3 years. And Zach just got accepted to OHSU for medical school. So selfishly, I'm hoping that we can keep him here for another several years. All right, with that, we'll transition to Dr. Reed Thompson, who does both radiation therapy and also bioinformatics, which is just numbers beyond that make my head explode. So I'm really excited to introduce Dr. Thompson.
Thanks, Liz, for the introduction. Good morning, all. Happy to be here. So yes, indeed, I'm a radiation oncologist. What that means for those who aren't already aware is that I treat cancers using high energy radiation. Obviously, we're talking about melanoma being caused by UV radiation, but this is therapeutic radiation to actually kill cancer cells, so a little bit different. We use radiation as a tool for all different kinds of cancers, and it's one of the key pillars of cancer care. Even with all the emerging therapies, radiation's been around for a long time, it's proven to be very effective. In melanoma, we tend to use it mostly for really complex cases. So it's not really kind of a run-of-the-mill therapy for patients just being diagnosed, see a spot, have it removed, that kind of thing. But for more advanced cases, more complicated cases, it's definitely key. I'm happy to talk at length about kind of how that is emerging, how that's evolving, excuse me. Certainly for my own research on this topic. We actually have an open study right now trying to understand how the focused radiation energy that was giving to a single spot, right, is actually affecting overall how the body is responding to melanoma. So if someone has metastatic disease in lots of different places and we're giving radiation to one area, what does that mean for the other areas that we're not treating? And we're measuring different signals in the blood to try to understand kind of what's happening from that focused dose of radiation. On the data science side, and when I say data science, I mean really thinking about just computers and taking all the population health data that we have. I do most of my work over at the VA, and as you may know, the VA is the nation's largest health system. It's pretty phenomenal in terms of the power that you can have to try to look at deriving new insights from population level data across the entire country. And this is really granular information where we have detailed information on each individual longitudinally through the veteran health system. So long story short, I'm not going to talk about all of the studies, especially in the interest of time. Happy to talk more at length as we break out. But what we're really looking to do with this data is try to understand melanoma outcomes, especially as related to kind of different kinds of interventions, how the changing interventions are resulting in changing survival outcomes or other outcomes that are important, obviously. So I'll keep it brief and at that, but really, again, appreciate you guys all being here and happy to kind of open the floor and hear what you guys are interested in talking about. We'll do that later, of course. Thanks.
Thanks so much, Dr. Thompson. All right, next up is Dr. Noah Hornicks, who we recruited from back to OHSU from Yale. He is sort of my colleague who works over at CHH2, and his primary passion is drug rashes due to oncology therapies, so cancer therapy-related drug rashes, primarily trying to keep people on their medicines while controlling their skin. And he also has a lab where he investigates how to do that even better.
Thanks, Liz. Hi, everybody. Thanks for being here. My name is Noah Hornick, like she said, and I also, like many of the people here, do multiple things at work. I am a dermatologist and I do a lot of skin checks. I also have a primary clinical focus on, as Dr. Berry mentioned, keeping people on their cancer therapies, no matter what kind of therapy that is. A lot of the different kinds of cancer therapy, whether it's radiation, whether it's traditional chemotherapy, targeted inhibitors that affect the proteins that cancer cells use to drive themselves forward, or immunotherapy, which is my major research interest, they all produce side effects in the skin. And those things can range from mildly annoying to life-threatening. And it's my job to make sure that those things are as tolerable, comfortable, or ideally prevented as possible and let people stay on the therapies that are treating their cancer. In addition to my clinical work, I have a focus in the laboratory that Zach was nice enough not to talk about so that I could talk about it, which is on the reactions that people have to immunotherapy. Immunotherapy, as it's used for melanoma and many other cancers, works generally by ramping up the immune system's activity against tumors. Unfortunately, tumors are not cleared by, the ones that aren't cleared by the immune system before they're treated are not cleared because they've found ways to use the body's normal mechanisms of protecting itself from the immune system to protect the cancer cells. So the immune therapies that we most often use basically shut down those protections to let your immune system attack a cancer that it has otherwise failed to delete. When you do that, you also unfortunately license the immune system to attack healthy tissue. And so we get a bunch of different side effects that recapitulate or look like autoimmune or autoinflammatory diseases elsewhere in the body. Obviously, I'm a dermatologist. My focus is on the skin, but just in the skin, which is the most frequent site of these side effects, we see a range of side effects that range from itch to eczema to psoriasis to autoimmune blistering diseases. There's a huge spectrum of them. And while they resemble normal or naturally occurring skin conditions, they also have differences, and the differences are what I focus on in the lab. The thing I'm most excited about right now is a project that I do have a project that works on recruiting patients who are actively being treated in collaboration with the Kulkarni lab. But the one I wanted to talk to you about today is a project that uses clinical samples that were already taken from different patients to diagnose their skin disease or their melanoma. And so we have these archived tissues that were fixed and cut into slides. And I'm working on two different projects that take those things that we already have and look at the inflammatory markers in those things, what cells are in there, what proteins and signals that they're producing, in order to understand how the off-target reactions to immunotherapy are like each other, how they're different from each other, and how they're like the skin reaction or the skin diseases that we're used to treating, so that we can know how best to leverage existing therapies for skin disease to treat those reactions without shutting down somebody's immune response to their cancer. And so to better do my clinical job of keeping people on the therapy that's getting rid of their melanoma. That's what I'm excited about. Thanks.
Such a fun job to be up here and glow about our faculty. Thanks, Dr. Hornick, for that wonderful encapsulation of what you do. Next up is Dr. Gina Chung, who's one of our dermatopathologists. So she's key involved in looking under the microscope and determining whether or not something is melanoma. And I feel like every time I work on a difficult case with you, I learn something. So I'm really excited to hear what you're excited about.
Thank you. All right. Hi, my name is Gina Chung. Thank you, Liz, for that wonderful introduction. I'm a dermatologist and dermatopathologist at OHSU. So I'll try to give a brief summary of what I do. I don't know why the photos aren't showing up. Oh, here we go. So when you come to OHSU and you get your skin biopsy done, so it will be read by one of three dermatopathologists. So Dr. White, Dr. Magnan-Kuhn, and myself. And something important to know is that we are all board certified, fellowship trained dermatopathologists. So when you get your biopsy done, it's also important to know where is it going, who is it being read by. And we are also dermatologists who see patients in clinic as well. And I personally think that that helps me become a better pathologist as well, because I take what I see in clinic and then I relate to what I see under the microscope. And so this is me at my desk, usually sitting at my microscope. And we also have a multi-headed scope in where we teach residents and fellows as well. So we are actively involved in educating people, residents and fellows to read slides as well. So when you get your biopsy done, there's different types of biopsies, as you know, like a shave biopsy that's done with a razor blade, or a punch biopsy that's done with a punch biopsy tool. Sometimes your dermatologist will take a scalpel and do an excisional biopsy. So when you get your skin removed in clinic, it looks something like this. And then your dermatologist puts in a little bottle and says, okay, we'll call you in about 3 to 5 business days with the results, but you don't see where that specimen goes. So basically, when we received the tissue in the lab, it gets sectioned. So depending on the size of the biopsy, it will get either cut in half, or it can get what we call bread loafed, where we cut it serially. And basically, we place the tissue in a little cassette, and then it gets embedded in paraffin wax. And then the wax block is cut into very thin sections that are 3 to 5 microns thick. So they're incredibly thin slices. And then we basically float them in a little warm bath, and then we pick them up using a glass slide. And then using an automated machine, the slides are stained, and then the slide is ready for pathologists like myself to review it. So this is kind of what your skin biopsy would look like under the microscope, depending on what kind of biopsy is performed. Either a thin shave biopsy with a razor blade, or a punch biopsy with a punch biopsy tool. So what do we look for? So in melanoma, the most important cell is the melanocytes, which are usually in the epidermis, but can be in the dermis as well, which is a deeper layer of the skin. And we can tell which are melanocytes because they have a very characteristic appearance. They have a slightly darker center, and then they also tend to have a little space around the cell. And basically, we just kind of look at it and then we decide whether something looks like a benign nevus or a melanoma. So this is an example of like a benign mole that you can get anywhere. And here you can see that the melanocytes are very kind of monotonous. They're kind of similar to each other. They have a regular distribution. They're symmetric. Whereas in a melanoma, that symmetry and regular architecture is destroyed. And you have these big atypical appearing melanocytes. There's increase, there's, sometimes they move up higher into the epidermis where they shouldn't be. And usually it looks very atypical compared to what you would see in a normal mole. So you can see that this is something that requires a little bit of experience because you have to know what's normal to know what's abnormal. So we also do other adjunctive molecular tests as well. So there's different tests that you can do when you're not sure. So you can sometimes do something called fluorescence in situ hybridization testing, where we look for very specific mutations that are known to be expressed in melanomas. We also have this exciting tool called single nucleotide polymorphism microarray, where we basically look at chromosomal instability. So on the right side here, you can see that a melanoma, which is on the top, has a lot of more instability, which you can see in this graph, than a normal nevus, which tends to have a lot more stable chromosomes. So that's another test you can use. And then you can also do, if it's a big lesion, you can also do DNA sequencing to look for about 500 to 600 genes that are common to certain cancers. And we can also do gene expression profiling tests. And there's actually this 31 gene expression profiling test that can help predict the risk of metastasis in melanoma. And OHSU, especially Dr. Leachman and Dr. Vedo, were very key scientists in this research. So lots of exciting things coming up as well. So if I can give you some advice as a dermatopathologist, I would recommend establishing a relationship, if you haven't already, with a dermatologist who has a relationship with one lab. Because if you think about it as a patient, you don't want to jump from doctor to doctor to doctor. You want to go to one doctor who is familiar with your medical history, knows what conditions you have had in the past, and use that information to diagnose your future conditions as well. So if you come to OHSU, all your biopsy specimens are in one place. We know exactly what you had 10 years ago. It's all in our medical record. So we can use that as a context. And as a dermatopathologist, I also think it's really important because sometimes you see certain patterns in moles as well. So something that might look atypical in someone else may not be atypical for you if all your moles have that pattern. So it's really, context is so important in dermpath. So I would suggest trying to kind of have like one lab reading your slides and know who's reading your slides. Ensure that your skin biopsies are being read by a board certified fellowship trained dermatopathologist because we have additional training and we usually read a lot more skin biopsies than non-board certified pathologists. Here. Thank you.
Thanks so much, Dr. Chung. I hope you all get an appreciation looking at those histology slides, those skin slices under the microscope. Super nuanced. It's really hard. I mean, it is a blur of pink and brown and purple and blue. And we're really, really fortunate to have 3 dermatopathologists who have really wonderful experience. Okay, next up is the newest member of our melanoma team, Dr. Christian Valenzuela, who's coming to us from a fellowship at Wake Forest. And he is one of our surgical oncologists, which they're the surgeons that remove the melanoma that is slightly more advanced and do the surgery to check the lymph nodes. And I'm excited to hear what you're excited about.
Hi, Liz. Thank you for having me. Thanks, everyone. So my name is Christian Valenzuela. I'm one of the surgeons. For anyone who's lost, the motorcycle and leather convention is 1 block that way. So you can go after. So I've been here at OHSU for about 6 months. I'm originally from New York, and it's a pleasure and an honor to be here as part of the community of caretakers, as well as serving the patient population here, you guys. I just want to take a few minutes to describe briefly the basic, most common operation that we do. It's me and John Vetto is the other surgical oncologist who primarily does the melanoma operations here. And for first presentation of limited or localized melanoma, it's a two-part operation. The first part is a wide excision of the melanoma. So many people think, well, why can't I just remove that mole? And that's it, kind of like what a punch biopsy would be like. The principle behind doing a wide excision is you have to remove not just the mole, the melanoma, you have to remove the surrounding skin and the fat tissue all the way down to muscle in order to capture any cells that are on their way to the lymph nodes or on their way spreading. It include the dermal lymphatics, the lymphatic vessels under the mole. So melanomas, like many cancers, they like spreading through a system of tubes that we have called the lymphatic vessels that connect to the lymph nodes, which we have all over our body. You know, like when you have your colds and upper respiratory illnesses, you have the lymph nodes swelling up in your neck. Well, they're all over the place. And we actually have an independent set of tubes that run between them. And those are under all the skin. And we have to capture the lymphatic vessels right under the tumor. So that's the first part. For anything 1 millimeter or less in thickness, that's about 1/32 of an inch, it's adequate to do 1 centimeter or about half an inch of skin all the way around the lesion, and you have to go down to muscle. For anything between 1 and 2 millimeters in thickness, 1/32 to 2/32 of an inch, then it's acceptable to do 1 to 2 centimeters all the way around. And for anything greater than 2 millimeters, you have to do 2 centimeters all the way around. Doing more than 2 centimeters or about an inch, with current evidence, there is no benefits to removing more skin and tissue than that. There have been numerous trials over the past few decades doing even wider margins, and that doesn't really affect survival. So 2 centimeters or about an inch all the way around for anything more than 2 millimeters is the adequate and appropriate operation. So that's wide excision. In limited circumstances, you can combine the sentinel lymph node biopsy with Mohs operation, and Wesley is going to talk about that. But for the majority of lesions that are on the trunk or extremities, then wide excision is the primary mode of operation. The second part is the lymph node biopsy. So how do you do that? Well, you have to pick up whether or not the melanoma has spread to the first group of lymph nodes that drains that particular patch of skin and goes through the lymphatics. And you do that with flagging the particular or sentinel lymph node. And you do that with 2 markers. The first marker is a technetium-99. It's a radioactive tracer, a very small quantity that's safe. You can even give them pregnancy. And that runs through the lymphatics the same way a tumor cell would and flags the 1 or sometimes up to 3 lymph nodes that is corresponding to that patch of skin. I have a handheld Geiger counter in the OR, and we're able to see with an image, a special X-ray before you go to the OR, and in the OR with this handheld device to select that lymph node. I also inject a blue tracer, a blue pigment called isosulfan blue, which also actually visually tags the lymph node. And then let's say if the lesion is on the arm, then typically the lymph node that we select is in the armpit or the axilla. If it's in the lower extremity, then you go into the groin. And head and neck is a lot more variability, but that's the same principle no matter where you operate. And with that, once you have it's informative, because if you have melanoma in your lymph node, then that puts you at a stage 3, and that means that you just need some treatments after the operation, namely nowadays immunotherapy. And if you don't, then usually surveillance is adequate. So that's kind of what I do. I'm typically the first point of contact for patients coming in to the OHSU patient community, because usually there's a dermatologist in the community who does a biopsy. If it comes back melanoma and it's thick, then they send us here, and usually it's the surgeon. And then it's my role to plug the patient into the tumor board and coordinate, make sure they meet everyone that they have to here to coordinate their care. So anyway, thanks for having me. I'm happy to answer questions later.
Thanks so much, Dr. Valenzuela. It's always wonderful to hear a good encapsulation of what goes on in the operating room and the rationale behind that procedure. Okay, next up is Dr. Joanna Ludzig, who is the co-leader of our OHSU Skin Imaging Center, where she does all sorts of really spectacular, groundbreaking, non-invasive imaging technology to see if we can diagnose melanomas earlier.
Thank you for your kind introduction, Liz. Today I'm going to be talking about imaging and telehealth for early skin cancer detection. So my goal is to manage skin cancer patients wherever they find themselves in their skin cancer journey, and the ultimate goal is to prevent mortality. So what are we using in the clinic? At this moment, we're using, of course, dermatoscope. Dermoscopy is taught in dermatology residency programs. It's standard of care, and Dr. Liz Berry and me are running actually our dermoscopy booth sessions for our residents and fellows. Thanks to dermatoscope, we're able to see what's going on at the surface and subsurface structures in the skin. Actually, it's just a simple light that we use to perform full body skin exam and identify skin lesions of concern. We also have an option to use smartphone dermatoscopes in our clinic. It's easy to use on any smartphone or iPad device. Thanks to this device, it's easier for us to document any lesion of concern right before biopsy. We also use this type of a tool in our e-visit and virtual setting. What it means that we used to ship those devices for free at no cost to our patients to help them to take good quality, high definition picture at home. So instead of just sending us clinical blurred pictures of their mole of concern, they had a chance to send us a high quality, high definition dermoscopy picture. Also, sometimes right before the virtual visit, we're doing that. And this is the difference that you have between clinical picture, naked eye image, and dermoscopy. Actually, there is a difference. So the other tool that we're using in our clinic is also reflectance confocal microscopy. This is another tool that we're using. It's a non-invasive optical, sometimes we call it a virtual biopsy. Of course, it's a painless type of a biopsy. It gives me information about the cellular resolution of the suspicious mole, and we can perform the screening in less than 5 minutes. It gives me some horizontal images of the suspicious mole, and thanks to that device, we can diagnose and check what's going on slightly deeper in the skin, actually without taking a physical biopsy. So how can a virtual biopsy help improve precision and reduce scarring? This is a case that we had a few months ago in our clinic. So a 52-year-old female patient with a history of melanoma came for a biopsy, was referred to our clinic for a biopsy of 4 concerning moles. So as you can see, all of the images look slightly maybe different, look slightly ugly for sure, ABCD criteria. So based on the criteria, they're all slightly concerning, but do we really need to perform 4 physical biopsies? Would you like to have 4 biopsies done? So we decided to take dermoscopy pictures, and of course, based on dermoscopy, we should proceed and perform biopsy. In that case, we would have 100% sensitivity. But what about our precision? So thanks to confocal microscopy, thanks to the additional information that comes through from this screening, we're able to check that 3 of those lesions were actually benign, and we didn't find any atypical cells, and actually one of the moles had some atypical cells, and this is the particular mole of concern. And actually, those are the ugly looking cells that we found thanks to confocal microscopy. As you can see, 2 areas, 2 regions in that mole actually had atypical ugly looking cells, but not the entire lesion actually was ugly looking confocal. And I think this is pretty interesting, especially if we have larger moles. Sometimes not the entire surface is looking ugly, atypical in confocal microscopy. So to better communicate with our pathologist, especially with Dr. Gina Chang, we mark those 2 areas of concern using a special ink. Actually, it's also ink that we use to do tattoos. And we marked this area, and it happened to be a melanoma in situ arising in the nevus. So actually not the entire lesion was a melanoma at the time of the diagnosis. And this is a case number 2 that I want to share with you. It's a special case. We have a history of this lovely female coming to our clinic a few months ago with a history of BCC for focused skin cancer, exam, and then one of our providers, it wasn't me, found a concerning spot on her right cheek, and he decided to perform confocal microscopy. As you can see, there are some ugly looking cells, there's some chaos. You don't need to be a specialist to see that something is going on this image. And based on this image, he decided to take a biopsy, punch biopsy, and it happened to be a melanoma in situ. Dr. Gina Chang already talked about some other options that we have to confirm if actually the lesion is a melanoma. Some other tests were performed, and this case was actually published not so long time ago in one of the journals, medical journals on PubMed, and it happened to be the smallest skin cancer detected so far. And on Monday, we're going to receive a certificate from World Guinness Records as a celebration of this journey. This is the entire team that participated in the diagnosing and validating process. So Dr. Witkowski, me, Dr. Gina Chang, of course, and Dr. Sensi Leachman and Professor Pelacani help with the validation process. He works in Italy. Thank you so much for your attention. And maybe one more slide to share with you. We also informed White House about our accomplishments recently. Someone on our behalf did it. So we also received a letter from President Joe Biden. Thank you so much.
Thanks, Dr. Ledzik. You can see we're truly stepping into the future and kind of riding that wave of technology that will revolutionize the way we take care of people. And as far as I know, you guys are the only ones in our department to have a Guinness Book of World Records. So congratulations. Maybe the only one at OHSU. All right, next up is Dr. Wesley Yu, who's one of our Mohs surgeons, but who also wears a number of different hats. I'm not sure how many hats you're going to talk about today, Dr. Yu, but he's going to talk about mostly kind of a modified procedure for treating melanoma surgically.
Thank you, Liz. This is great. Yes. Thank you, thank you. Oh, yes, let me see if I can do. It's gonna work. Oh, it works. Oh no, wait, let's switch it. How do I switch it? Oh, thank you. Where's the mouse? Thank you. Thanks. I have technical difficulties sometimes. I promise you that never happens when we're actually doing surgery. So you've heard a lot today from public health, war on melanoma, to radiation for advanced ones, science, diagnosis. I'm going to talk to you a little bit about surgery, going off a little bit of what Dr. Valenzuela talked about. And I'm going to start by saying that most melanomas are localized, right? They're on your skin, they haven't spread yet. And the primary treatment for those is surgery. And most of those melanomas can be cured. They can be cut out and you're done. But for some people, that melanoma comes back. It spreads and it causes real problems, right? So if you have a recurrence and progression, you have increased mortality, your quality of life is impacted. And there's a lot of cost associated with treating that melanoma once it's out of the gate. And so if you have a melanoma, if you're one of the many people who has a localized melanoma, I think probably one of the first questions you're asking yourself is, how can I prevent this from spreading? How can I prevent this from coming back? And so what my group works on is essentially a two-pronged approach to making sure that melanoma doesn't come back. The first part is optimizing surgery, making sure that when we do surgery, you have the lowest chance of having that melanoma come back. And then the second part is chemoprophylaxis. So this is taking people who are at high risk of a recurrence or progression and treating them with a low-risk medication that can prevent that progression, okay? Now I'm gonna focus on the first part today, just to make this as clinically relevant as possible. So we'll talk about optimizing surgery. And Dr. Valenzuela talked about this a little bit already, but when you have an early melanoma, one of the questions you're probably going to be asking yourself is, you need surgery, what are the options? There are two main types of surgery that we use for melanoma, okay? Dr. Valenzuela does wide local excision, which is cutting the melanoma out with margins and then bread loafing through that. We heard about bread loafing from Dr. Chung. What I do is Mohs surgery, which is cutting out the melanoma and then looking all the way around its peripheral edge instead of bread loafing through it. Now, you might say, well, how are those two things different, right? You're looking at the melanoma. Well, when you're going through the center of the melanoma, you can see that melanoma trail out to the edges, right, when you're bread loafing. When you're doing Mohs surgery and you're looking at the edge, you cannot. So it does make interpretation of that margin a little bit more difficult. On the other hand, if you're bread loafing through it, you're leaving gaps, right? So there are some places that you might not see. Whereas if you do Mohs surgery and look all the way around it, you're seeing everything. So pros and cons, okay? And so that's why it's really important to be really selective with what kind of surgery you're doing. We just recently published a opinion piece about this in NEJM Evidence, going through sort of the different pros and cons. Oh, and actually before I do that, so I'm gonna be showing some pictures of surgery. So if you are squeamish or don't wanna see that, go ahead and close your eyes. I see most people's eyes are open. So, all right. So these are just a few of my cases where we've done Mohs for early stage melanomas. So this was a gentleman who had a melanoma on his eyebrow. We were able to close that very nicely and keep small margins, and he turned out very nicely. This is a woman who had quite a large melanoma on her lower eyelid. We did a nice repair, and that was her 6 months later. And so we are able to create really good results for people on the head and neck. And so coming back to the question of what treatment should I get, I'm going to say, very importantly, for most melanomas, standard wide excision remains the best treatment, right? So most of the time, you're going to want to see Dr. Valenzuela. You're not going to want to see me. The second thing to say is that there's no data to directly compare these two surgical methods. So one of the things we're working on is to generate that data, right? We want to make sure that we know exactly which patients we should select for what treatment. And so we're actually starting a clinical trial to assess that. So we're going to be taking patients with melanoma in situ or T1 melanomas, randomizing them to the two types of treatments, wide local excision with bread loaf or complete margin assessment, also known as Mohs or slow Mohs, and following up on their outcomes. This has sort of been a long process. It's been years of planning. We're currently at the final stage, which is funding, and we're hoping to get some good news on that in the next few months. What can you do right now? If you want to help us with research, we are always looking for people who are interested in giving us feedback on our trial, helping us design that and helping us run it. I put my email down here, so if you have input that you want to give on this kind of trial, we are forming a patient advocacy group that is going to help inform this trial. I'm only one of the Mohs surgeons here, so if you need Mohs surgery or something like that, you're always welcome to email me, and I can connect you to the right person. All right? Thank you. Oh, and actually, quick acknowledgements. I just want to thank all the people who have helped with all the research parts of my job. Thanks.
Thanks so much, Dr. Yu. I think it deserves a level of appreciation for how much work he's put into putting this trial together. Anytime you're trying to change the way we do things in medicine, it takes a huge sea change. So, answering the question of is wider necessarily better for melanoma is one that's really, really important and remains to be addressed. Okay, next up is Dr. Amy Cohn, who I just cannot rave enough about. We work really closely together in our melanoma multidisciplinary clinic. She's our medical oncologist, which means she's giving therapies for people with advanced melanoma. So Dr. Cohn, I can't wait to hear from you.
Thank you. Thanks for having me. So I practice general oncology with a focus on melanoma. And I'll give a broad overview of what's hot, what's moving forward in terms of treatment. So I think the first category is there's a lot more talk about neoadjuvant treatment, meaning do a little bit of treatment before you get to surgery. A lot of that is with the focus on immunotherapy with a general concept of basically prime and educate your immune system when you have a bulkier tumor, then cut it out and then do the rest of treatment. The second category is the adjuvant treatment, which we're, I think, a lot more familiar with, meaning you have a more advanced but curable melanoma, and now we want to give treatment to reduce the risk. Probably the biggest thing there that has gotten a lot of press is through Moderna. Everyone now knows or has heard Moderna with the COVID vaccine. So they also have a research program with melanoma combining vaccine with immunotherapy. They had a phase 2 trial that they had a press release suggesting increased efficacy, and we were able to participate in that. I think in the setting where melanoma has spread, so where it's metastatic, I think two big categories are thinking about new drugs that can help overcome resistance to immunotherapy. The other big category is, I think, tumor infiltrating lymphocytes. That's gotten a lot of, I think, lay press that has not fully representative, but a pretty involved procedure, but has some promise to it. And we will be opening that in the next coming months to have that available. And I think the other kind of unsung hero that we haven't heard a lot about is targeted therapy, which has been, really effective for many people. And I think the issue has been really finding and identifying new targets. And that's where our phase 1 team that we work with has come into play. And that one big target we're looking at is for NRAS, which some melanomas include. And in the phase 1 population, there's also antibody drug conjugates, I think, is another wave of development. And then the last big frontier, which will transition to the next speaker, is for uveal melanomas. It's really been an incredible evolution over decades from the basic science to now clinical trials. And there's now a new drug that's become available called Timtrac. And I think the issue is really now finding more drugs to support that population. And I talked really fast, but I think.
Thank you so much, Dr. Cohn. And when we do our breakout sessions, I'm sure you guys will have lots of questions for her, but she can officially say we knew about Moderna before they were cool. Okay, well, next up is Dr. Afshan Nanji, who is one of our ophthalmologists. So believe it or not, you can get melanoma in places where you don't get a whole lot of sun exposure. So she's going to talk to us about melanoma that happens in the eye. I do have some slides. Yeah, just go through. Okay. All right. So I'm going to talk about melanoma that happens in the eye and on the surface of the eye.
So let's start with melanoma that happens in the eye, because that's actually the more common type of melanoma on the eye. So this is uveal melanoma. So what is the uvea, right? I think the number one question I get asked from patients, or the comment I get when patients come in with melanoma is, I didn't know this could happen. So where is the uvea? So the part of the uvea that you can see is the iris. So if you look at someone's eye, the darker part of the eye that has color, that's the iris. But there's also uvea that extends the ciliary body. And then the majority of it is this purple part that goes, it's actually black, but in your eye, but the choroid, which goes all the way around the back. And so that's the bulk of the uvea, is what you can't see. And that's the pigmented layer of the eye, which is why that's the most common site for melanoma. So when you get a melanoma in the eye, the most common place is in this choroid, which you can't see from the outside. So about 85% of them occur there. So this is the most common type of ocular melanoma. But as we talk about melanoma, this is still pretty rare. So when we talk about the population of Oregon being 4 million, this occurs in about 6 people per million. So, 24 people in a year. So still not very common. But people don't really present with symptoms. So the majority of patients don't have symptoms. Some will have decreased vision, some will have flashing lights. And if you have any of those symptoms, remember, this is pretty rare. You should get an eye exam, but probably this is not the cause of the decreased vision or flashing lights. But this is one of the reasons why it's so important to get regular eye exams, because a lot of the diseases, including melanoma, that are the worst in the eye, you really don't have symptoms from. And treatment is often, so the other question that we tend to get is, does my eye need to be removed? But actually for uveal melanoma, the most common treatment is actually with radiotherapy. A plaque is placed on the eye to direct treatment to that uveal melanoma. So this is what a melanoma in the eye might look like. And the person actually that someone would see for a uveal melanoma is not me, but Allison Scallett. So there's 2 of us who work on oncology in the eye. So the part that I deal with is melanomas that occur on the surface of the eye. So the surface of the eye is the cornea. So that's the clear layer. When you look at someone's eye and see their iris, there's actually a clear layer on top of it called the cornea. And the conjunctiva, which is a translucent layer on top of the white part of the eye. And that white layer does go all the way around. But melanomas on the surface of the eye are actually much more like skin melanomas than the other types of melanomas in the eye. So they are sun-related, and so they tend to occur right on the surface where we can see them. So this is an example of a very small melanoma on the surface of the eye. These are even more rare. So these are about half to 1 person per million per year, so even more rare. But these can be spotted. So a dark and growing spot on the eye is definitely a reason to be seen. Treatment for this is generally with excision, like we heard about, with wide margins. Our margins are smaller on the eyeballs. You can imagine we can't take a centimeter on the side. So we're talking about basically about 4 millimeters is our wide margin. And then applying cryotherapy or freezing therapy to the edges of that to really make sure that it's all gone. So what's new in ocular melanoma? So targeted treatments, like you just heard about, looking at genetic markers and really targeting, and that's really more for once the initial treatment has happened and patients have metastatic spread to the rest of the body, so more targeted treatments. Non-invasive forms of diagnosis. So, we talked about uveal melanoma being the most common. It's in the back of the eye. So getting a biopsy, that is putting a needle into the eye and getting cells. You can't really take like a piece of tissue the way we can on the surface of the eye. So it's less accurate than if we could get a big piece of tissue like I can from the surface. And so looking at other non-invasive forms to be able to make this diagnosis better. You also heard about a new treatment for metastatic uveal melanoma a second ago too, which is also new. And then for surface melanomas, also looking at evaluation of lymph nodes. So you heard from Dr. Valenzuela about sentinel lymph node biopsy. So the same type of thing, that when I'm doing a primary excision, injecting that blue dye so that someone like Dr. Valenzuela can come look at the nodes and see if there is spread right off the bat. So those are the new things, and I really look forward to talking to you guys all more during the breakout session.
Thanks so much, Dr. Nanji. I feel like it's always good to have a reminder of ocular anatomy and the things that go on. And also to mention that having skin melanoma and eye melanoma is extremely rare, but there are some genetic predisposition syndromes, which means your melanoma runs in family. There's one in particular called BAP1 that predisposes people to having both eye and skin melanoma. Okay, well, we're into the home stretch. So Dr. Megan Ruland is going to bring us home. So she is a basic science researcher, which means she works in the lab. She's one of the ones that makes the discoveries that eventually kind of trickle down into therapy. Yeah, so I am a researcher, which means I have a PhD rather than an MD. And so I spend most of my time running a lab that investigates how the immune system responds to cancer and how we can use the immune system to better target cancer and eliminate melanomas. And when you think about the immune system is very good at doing things like identifying viruses or bacterial infections and then clearing those from your system. And that's what helps keep us healthy. But in the case of tumors, in some cases, the immune system can identify a cancer, and these are usually really early. There's a damaged cell. The immune system identifies that and then eliminates it from the body. But in the cases of growing tumors, the immune system comes in, but there is a problem with it actually being able to kill the tumor cells. And so then the tumors will essentially grow unrestrained by the immune system. And so a really great development that has been revolutionary in the treatment of melanoma and other cancers is the discovery and development of cancer immunotherapy. And what several people have discussed already today is these cancer immunotherapies, instead of targeting the cancer cells, what they do is they target the immune system and reverse this effect of shutting down the immune system and instead ramp up the immune system so that it can start doing its job of killing and eliminating the cancer. And what has been the most successful of this class of immune targeting drugs is termed checkpoint blockade therapies. And getting into the nitty-gritty of what these therapies actually do is that they target a very specific cell type in the immune system that's called the T cell, and for good reason, because the T cells are actually the part of the immune system that can see a tumor cell and directly kill it. And so in this way, checkpoint blockade therapies boost the T cell function and result in tumor elimination. And in the case of melanoma, these have been really impressively successful in that in advanced disease, around 60% of patients have response to this therapy. But that does leave about 40% of patients that are still not responding. And what my lab does is we focus on the basic biology of the immune system in trying to find new ways that we can target the immune system to improve responsiveness to therapies and develop new therapies that then can broaden the patients that are able to achieve response. And our focus is on a different cell type than the T cell. We focus on what's called a dendritic cell. And the reason we're focused on dendritic cells is because they're actually the instructors of the T cell attack. So in the immune system, they tell the T cells what to do. And so if we can engineer the dendritic cells to be better at telling the T cells what to do, then the idea would be that they generate better T cells or more T cells that can then go on and kill the tumor. And something super exciting in my lab right now is a project that we have going on that's investigating the role of hormones in controlling immune responses. And we know from other diseases that hormones are really impactful in the immune response. And what we don't fully understand, especially in the case of melanoma, is how hormones are impacting the immune response to the tumor. And so what we found in a new project and new data that's coming out is that testosterone is actually really suppressive on the role of the dendritic cell in driving these tumor-killing T cells. And so we're working to engineer this dendritic cell to be non-responsive to the hormones or testosterone in the body so that it is better at driving these really productive T cell responses that kill the tumor, with the hope that this can be paired with things like checkpoint blockade or expanded to patients that don't respond to checkpoint blockade to open up cancer immunotherapy to more patients. So
I look forward to questions later and meeting all of you and discussing more, but thank you.
Thanks, Dr. Ruland. And it's discoveries like this and understanding the fundamental way the immune system works that are going to continue to drive our field forward. And also understanding that kind of like the one size fits all approach to treating cancer may not necessarily work. So we're going to continue to be able to tailor our therapies, based on testosterone levels and other factors to help make those therapies better. Okay, I think Patrick is going to give us some more housekeeping.
Yes, I know we're running a little bit behind. I'm not going to take your break away because I'm not rude, but getting hundreds of years probably of combined research and expertise takes a little bit of time to get out. That being said, we're going to be very prompt with our 5 minutes, and we're going to transition into our meet and greet section. So one thing you can do is on your agenda, which you have in your folder, you're going to have a number 1, 2, 3 on the top of your agenda. That's going to correspond to which area you are going to go for the breakout rooms. So group 1 is going to be in the classroom that's next to us here. Group 2 is going to be on this side of this classroom that we're in currently, and 3 is on that side of the classroom. So be prepared to do some moving and shaking for you guys, not for them. All right, ready, break. Really across from the other side of this wall here.
Hello, everyone. This is Ann Taylor from AMIT Melanoma, and I am running the virtual breakout session that will start in about 5 minutes, and we will get started. I'm gonna lift you up and take you into the breakout room.
You guys will be cozy space and then
Stay with us. Here we go. We have a lot to move. No, it's okay. I'm talking to the folks online. Okay, here we go. Going into our breakout room. Okay. Here we are. Panelists will be joining us in about 5 minutes. That gives you just enough time to refill your coffee. And our first group will be talking about dermatology. We have one question so far for that group. When they come in, initially, they will be talking a little bit more about their work, and then they're going to take any questions that you have for them. So thank you so very much. And we will start here in about 4 or 5 minutes. Thank you. You're with the dermatology group? Yes. Okay. So here we are live. You're going to sit right here. That's right. We have, so far, we still have about 20 people online. A lot of people have gone to go take a break, as we all are. Yes. But my understanding, hello?
Yeah, set it however you want.
Okay, I'm gonna let, there's 3 of you, I think. So we'll, so this is your computer. They can see you live now. We're on live, and okay. They know that you probably will have a few comments before you take questions, and I know that there's one for dermatology already on there. Okay. Okay. I'm plugging you in, so we'll stay live. Okay, let's see.
And can you reposition the camera just a little bit? Like,
Let's see. He gave us 5 minutes, so 3 or 4 minutes from now. Got it. Okay. Okay, and then we have 10 minutes. Okay. So let's see. Alrighty, I'm going to pull up the Q&A. Okay, so we have 3 questions here. And so I know that you have you want to say a little bit more about your work. And then this is what they can see. Here, let's pull this out of the way. Well, let's do it this way. Okay, there. That's not going to want to do. Okay, so here's what they can see, and they can hear you. We are unmuted. And so they will see and hear you, and then your questions are here as they come in. Okay.
Where's the camera on the screen here?
Right, you'll just have to love each other, squish in together. And I'll be over here, and then when our time is up, I'll go get the schedule. When our 10 minutes is up, it's time to change. I don't know if they're going to sound a horn or what they'll do, but then when you leave, I'll sit in front of there and explain who's coming next, and then they'll add more questions.
And we know where we're going next?
I don't know where you're going next, but I can find that out.
I think the
There's really where we move back around.
so.
Not countdown.
Yeah.
We go the other direction, it's counterclockwise also.
I think it's 4, 1, 2, 3. I think.
Okay, so you already have 3 questions. Sally.
Okay.
Very good. Thank you so very much.
Here, let's get in the chair. We got 3 people, or
Yeah. I'm just all fit.
Yeah, then just rotate the laptop as relevant.
Yeah.
Okay.
That's good.
And I
think front and center.
Oh, I know. I'm looking to the other
see.
side.
This is.
And
Can't just be me.
so.
Good morning, hello. Hello.
Let me check with Eric and ask him.
Also push the table out.
Yeah.
That's true.
Our folks are there,
Okay.
waiting for you.
Where do we see
Hello.
the questions?
can you hear me? Can you hear me,
Here.
guys?
And they will, you'll be able to tell some are for the oncology group that's going to be coming to talk or
Yep.
whatever, but I have invited them, I was doing this live over, and I've invited everybody who had dermatology questions to go ahead and load them in. So these should primarily be for you.
Okay.
Okay. And there are 2 more coming. I just see these now. And then I'm writing to Eric to ask him, are we live and can we start?
And can you hear me?
Okay. Good morning all. Reed Thompson here.
Hi, Afshan Nanji.
Amy Cohn.
I'm not trying to dominate the screen, I promise you, but unfortunately we have a little laptop here. So anyway, good morning. We have some questions up here. The first one that's being asked, is there any way to tan safely? Is spray tanning safe? And do you have any concerns about the chemicals contained in those sprays? This is not something I am a subject matter expert on, and so I'm not going to be able to give you an authoritative question. There are other folks who will be rotating through who can. Amy, do you have any comments about this at all, or?
I suspect the answer is no, but I know dermatology is going to be rotating in one of the next sessions, so we might want to wait on that one.
Yeah.
Oh, goodness. Okay, so what is your subject matter? I apologize. I thought
So-
dermatology was first.
So
I'm medical oncology.
I'm a radiation oncologist.
And ocular oncology.
Right. So I'm reading the questions. It's a great question. I want to make sure that you guys are able to get a good answer to that. So we're going to punt on that question for a subsequent group.
Okay, they're asking online, can you tilt the screen forward a bit because you have bad framing?
Bad framing. Tilt the screen
We have
forward.
experts
Thank you
online.
for that.
Yeah, we can see it a
We
little
can-
more
we can
together
scooch
too.
in. We
As
can
long as
also-
you're okay with us.
Yes.
There you go.
All right. We're a little better now, right?
Is that
Okay.
better?
Good. The next question I think will be a little bit more on point for this particular group. And so it's Dr. Cohen Ruland. Can nivolumab and ipilimumab cross into the CNS, I'm assuming, into the brain, essentially, in adjuvant or neoadjuvant therapy and deal with small melanoma brain metastases or the formation of brain metastases?
So yes, and then actually probably both of us can speak to that. So immunotherapy can cross the blood-brain barrier. It can treat the small lesions. Sometimes if it's really small, we'll rely on immunotherapy alone. Sometimes we'll take advantage of the fact that between radiation and immunotherapy.
I apologize. It's not on mute. Okay, I apologize.
Okay, just keep going, I'm sorry.
So between radiation and immunotherapy, we can consolidate and help treat. So it's, I think the only risk or worry we have when we do radiation and immunotherapy together is an increased risk of necrosis, tissue death of the brain.
Yeah, and not to derail the conversation, I think tissue necrosis is a really important thing. The concept there is that, right, with a small part of the brain tissue that then dies. I mean, again, that's cancer in there as well, but there's a lot of garbage cleanup that needs to happen. And that garbage cleanup process can cause a lot of inflammation and swelling, and that can be really problematic in terms of kind of what the sequelae are. So we don't like when radiation necrosis happens, or necrosis in general happens, because of all of the kind of inflammatory sequelae. But indeed, there's a balance between kind of the systemic therapy effectiveness and kind of the use of targeted therapies. And in this case, I'm talking about radiation for brain metastases. If there's a bunch of brain metastases, then it's something that, we have to think about not really using any more of a targeted approach, but potentially treating the whole brain if the rest of kind of the body is controlled in terms of where the melanoma is. But obviously it's a case-by-case basis there. But when there's several brain mets, or a small number of them, radiation can be used very effectively to target and kind of spot weld the areas of disease. Again, it misses the bigger picture of overall taking care of melanoma metastases wherever they live, and that's really the main role of the systemic therapy in that case. But radiation and immunotherapy can definitely kind of work as a concerted team. I think there's a part of the question also about the prevention of metastases and the formation of them in the brain. Thoughts on that?
I think that's a hard question to answer because, there's no way to do a control of treat half the brain. So I don't think I can answer prevention.
Yeah, I mean, it's a great question, and I think it's part of an open area of our understanding. And indeed, controlling one side of the brain versus we have to think really about how to actually disentangle it scientifically. But it's a great question. So I'm going to turn the camera a little bit here for the next question. And the question here is, where does the primary develop in uveal or ocular melanoma? And is that in the eye?
Yeah, so the primary in uveal or in ocular surface melanoma is in the eye. There can be metastatic disease to the eye from a different location, but that is actually more rare than the primaries.
Okay. Let's see. There's a couple other questions that have just come up. So for Dr. Cohn, presumably, does the combination of BRAF and MEK inhibitors have more poorly tolerated side effects than BRAF inhibitors alone? And what is the difference in efficacy in terms of the combination of the two versus the BRAF only?
So one drug will be better tolerated than two. It does have lower risk, but you do compromise in terms of efficacy. So it is quite a bit different. That generally we really pretty much exclusively will prescribe the combination. I think I answered the question.
Yeah, just in terms of the thought process there, right? The rationale for using two agents versus just the one alone, right, is to reduce the statistical potential, right, for a cancer cell or cancer cells to have escape mutations that provide resistance to the therapy, right? So if you hit the same pathway from two different directions, then it's much harder to kind of evade the therapy. And so you can have good responses to both treatments, but often, and you correct me if I'm wrong here, but often the effects of the dual kind of, targeting are much longer lived, and you have better kind of duration of response. Can ipilimumab be given beyond 4 cycles?
Yes, sort of. So the standard way we do it, so for example, in the give ipilimumab, whether it's metastatic or adjuvant, we'll do it once every 3 weeks, 4 times as basically an induction treatment. And then we give it as a maintenance, which is once every 3 months or 12 weeks 4 times. So it's still a year of therapy. I don't think there's really data to go beyond that. I think the concern is from the original studies, which I think was really the big release behind or foundation for immunotherapy, was using high dose ipilimumab when it was like 2.5 times higher what we do now, and it was enormous toxicity. And in general, ipilimumab does have more side effects than the ones that we use more commonly. So we generally don't go beyond that total of 1 year. Could it, if there was a recurrence, let's say, a couple years down the road, could one potentially imagine a scenario of re-challenging with ipilimumab? I think so.
There's also some that I'm aware of, some emerging science and thought around, exhausting the immune system, right? I mean, if you just, sometimes more is not necessarily more, right? I think is the concept, although again, there's still a lot of unanswered questions there. Are there still circumstances when a patient should have all their lymph nodes removed, or is that no longer necessary? Yeah, I think that question we're going to come back to for a subsequent surgical expert discussion.
I have one about Facebook.
We have a question from Facebook. Okay, what is the question?
Has TIL therapy been submitted for FDA approval? If not, how long is the timeline for that approval? Is that for your group?
Yeah. So
could you repeat that to make sure that they heard that question online?
So the question is, has TIL therapy been submitted for FDA approval, and what's the timeline for availability? So I think it's still, they're kind of in the early phase of interfacing with FDA. So I think the timeline for availability as standard of care, we're a long way away, but timeline in terms of availability in the context of a clinical trial, I think we're within, I think 6 to 8 weeks.
Yeah, question on this side.
Oh,
here.
yeah. Do you want to read the question?
Yeah, sure. So there's a question here: how is melanoma of the choroid detected? So occasionally patients can have symptoms, but it's generally through routine eye exams. So more common is that, just like on the skin, kind of a freckle or a mole in the back of the eye will be seen, and that should be followed over time. But also sometimes just on a regular eye exam, melanoma is picked up. And so actually most commonly patients don't have symptoms and it's picked up with an eye exam.
Did this one, did that one. Okay, so this one here. There's a question about sunscreens that we're going to skip over because there'll be some experts here in the near term who will be much more able to talk about that.
Next one.
There's a screening for melanoma question, which again, we'll punt on, I think, so that you guys are hearing the answers that, again, from folks who are much better poised to talk about it. And then the next question, I believe this will be for Dr. Cohn. And the question is there a difference between pembrolizumab and nivolumab?
So the mechanism is very slightly different in terms of what it targets. The frequency is different. Pembro is every 3 weeks, Nivo is every 4 weeks. I'm not aware of a true head-to-head trial comparing one to the other to say one is better than the other, but I think they're generally treated as interchangeably. And, I would say generally, if one comes out with the study, the next one isn't far behind. So as an example, there's now with pembrolizumab in high-risk stage 2 melanoma, the first study was with pembrolizumab, and now there's data with nivolumab. And I think in general, we're seeing that although it's a cross-study comparison, the information is comparable. So from my perspective in picking between the two, a lot of times I'm driven more by convenience. Sometimes we have data on one and I'll go with the one where we have data. But otherwise I would view them as basically the same.
I have a follow-up question to that from my own person. have you ever seen a patient who was on one, switched to the other one, and somehow there was a difference in response?
Once or twice, we occasionally play that in manipulation. We also occasionally play it in terms of side effects. Occasionally it works, not 100%.
Can you talk about neoadjuvant therapy?
This is recent data where the idea was they gave 3 cycles of pembrolizumab. This is in the context of stage 3 melanoma. So usually, most commonly, there was, for example, lymph node involvement, and then they go to surgery, and then they continue on with the immunotherapy to complete a total of 1 year. The principle or the concept, we believe, is, I think I said it before, that we are basically training the immune system, that you have sort of bigger, bulkier disease that's more accessible for the immune system. So you're basically priming it. With only 3 cycles, it's unlikely that we're going to see a dramatic response and kind of miss the opportunity for surgery. And it's also a short enough course that it's unlikely we're going to see, rapid progression of disease. So I think that in terms of the result, it's really been an impressive gain in terms of at least progression-free survival. I think we're waiting on whether it translates to people actually live longer with that strategy. But it looks promising, and I think more and more we're doing it in practice.
We have time for one more question. This one's from Facebook as well. How long after a stage 2 diagnosis can a patient take treatment?
So typically, how long with a stage 2 diagnosis?
How long after a stage 2 diagnosis can a patient take treatment?
So how long after a stage 2 diagnosis can a patient take treatment? So this is in the context of high-risk melanoma, where we offer immunotherapy, and there's only data for immunotherapy, not targeted therapy. It's typically 1 year of therapy. We don't go longer, and I think that's really that standard of 1 year of therapy has been established in the context of stage 3 melanoma. If it were metastatic, we usually don't go more than 2 years. So 1 year of therapy.
Okay. All right, well, I think it's time to switch, and I don't know which room you go to.
We'll figure out. Thank you all. Best wishes. Have a happy weekend.
Thank you.
And we'll meet all together again in the room for more questions, if some other questions come up for you guys. Okay. Okay, everyone, our dermatology group is coming in now. They'll be here in a few minutes. We do have a few questions for people who they've already asked questions for our dermatology group, but we invite you to go ahead and place your questions in the Q&A tab, and they will scroll through them as our oncology group did and answer them. So thank you very much for your attention, and we should be back again with our next group very, very soon. once again, please bear with us. We have our dermatology experts coming in a minute. And we encourage you to put any questions that you have for this group into the Q&A, and they'll be here in just a minute. I apologize for the wait. While we're waiting, if you would like to do so, please put something in the chat about where you're viewing from and share maybe with one another, so we'll know who's online and how far we are apart from one another and yet together today, part of this community of people. I hear them coming. These are our dermatology. Come on in. Come in, come in. You're here. They're waiting for you. You'll be able to see yourself. There's already 2 or 3 questions for you in here. You'll just have to scroll here, and then our live streaming moderator will dismiss the questions for you as you answer them, and then they'll start popping up as you go. Trust me.
All right.
Try to snuggle in here. Yeah. How many people do we have online, Ann?
How many people? Right now we have about 20.
I'm not on. Yeah, we gotta.
It's kind of like talking to my parents on FaceTime, where it's just like my dad's nose here, and I'm like, Dad.
We need information. Yeah.
They're enjoying
Act like
this.
we like each other.
It feels very intimate. And in the meantime, we'll also get questions from Facebook, and I'll call those out to you. Go right ahead.
Hi, Sansi, we miss you.
Right. We start at the top of the list here on the
Just
left.
if you would just look and see, if that question pertains to your group, will you answer it? Yes.
Oh, okay.
Perfect. Let's see.
How do we want to?
Do we want to do the?
Yeah, I guess so.
I know there's one about tanning. for
Yeah.
instance.
Okay. Yeah. So okay.
Go ahead.
Start with that.
Sure. Yeah. Do I have to click answer live, or do I just start talking?
You just start talking.
Okay.
You're
Cool.
live.
Sorry. Yeah. I mean, we're not big fans of intentional UV exposure, but you asked about spray tanning, and coloration is not in and of itself an evil. So it depends on what it is you're putting on there, but spray tanning is probably your best bet in terms of not having an increased risk of skin cancer.
Yeah, the tan you get from a bottle or a spray tan booth is just kind of adheres to the top layer of your skin.
Yeah.
And from what we understand with years of experience with that is it doesn't increase your risk for skin cancer. But the ultraviolet radiation and tanning booths and tanning beds, and I do worry to some extent about this kind of like red light therapy and other therapies that are getting kind of hot at some of these medi spas, is we just don't know.
Yeah.
The tanning beds are totally unregulated UV exposure, and so there's really no way to safely use them.
There's a series of questions that came in because of that question, so I'm just going to read them all to you.
Perfect.
Okay?
Thank you, Ann.
I hope they can hear me. You may have to. Okay, so
We can repeat them.
But here we go. Is there a big difference between SPF 30 and 50? What should I be looking for in a sunscreen? And I heard that sunscreens are not safe. Isn't that true? Go.
Oh man, that's a loaded question. So when I gave my points about sun protection, in our data, when we were looking at the different sort of application ways that people apply sunscreen. So you're supposed to apply it really thickly, and that's the way the FDA has tested it. But when we actually, applied it and looked at it, and the amount of UV or ultraviolet light that the sunscreen let through, SPF 30, when applied like people normally apply it, actually let a significant portion of the ultraviolet radiation through, which was really eye-opening to me, because I'd counseled forever that SPF 30 is enough, it's fine, it's fine, it's fine. But really, it's probably not enough. SPF 50 is better, because when we looked at the SPF 50 with people really rubbing it in well, it actually outperformed SPF 30. And then loaded question, is sunscreen safe? There are only two components of sunscreens that the FDA marks as what we call generally safe and effective, and those are zinc oxide and titanium dioxide. And those are the mineral sunscreen components. The chemical sunscreen components may be safe, but there's more data that's needed. There was a study a couple of years ago that showed that if you're really at the beach and you're really applying a lot of those chemical-based sunscreens, there is some like blood level of them that was detected. We don't know what that does.
Exactly. You do absorb it, but what consequences there are of that are unclear.
Yeah.
And we don't have, it's really just a matter of, with most things, how much and how long matters a lot. And so we just don't know if somebody applies a lot of chemical sunscreen regularly, as we advise people to, for 30 years, what the consequences of that are.
Yeah. So just, if you're worried about that, I would stick with kind of the standard zinc oxide. There are a lot of companies that have formulations that are not as chalky or have a little bit of pigment to them. So I'm wearing one today that has some pigment in it, and I don't look super chalky.
I'm wearing a chemical sunscreen.
That says a lot. That says a lot if you're a dermatologist and you're using things. But that's our spiel. I would, the only sunscreen I'd say to absolutely avoid would probably be the spray sunscreens, right? Because there are a bunch of them that have recently been recalled because, the companies let some benzene in, and benzene is not supposed to be in sunscreens. It's a chemical that causes cancer, so don't use the sprays. But everything else is on the table still. All right, and
there should be more questions.
There are more questions. All right.
So there's a question about lymph node excision, and I don't feel like I'm the best person to answer that. So I'm gonna.
The surgeons are coming next.
Yes.
Promise they'll answer that. Let's see. So I apologize that we can't answer that. Okay, in checking the Start Seeing Melanoma site, it mentions a melanoma outreach screening unit. Are you able to comment on the use of this device?
Is that the dermatoscope?
I think it's the mobile screening unit. So the Night Cancer Institute.
Question louder.
Yeah. So in checking the Start Seeing Melanoma site, it mentions a melanoma outreach screening unit. Are you able to comment on the use of this device? So I think there are a couple of different outreach programs we have that are on the Start Seeing Melanoma. There's, I think, a van that goes around that's associated with the Casey Eye Institute that we pair up and do skin screenings all over the state. And then the mobile dermoscopy device that Dr. Ludzig was talking about, that slip device that clips onto a smartphone. We've in the past had like a loaner program where you could like write in and get us to send them. We closed down the loaner program for now, but the device is still available and it's really, really cheap. It's like $99.
Using them is very straightforward. It's essentially, it's just a matter of putting it on your skin and taking a picture with your cell phone camera. It's
really cool.
Yeah, not a challenge.
It's really cool. I mean, you like snap it onto your phone, you turn the light on, you put a little bit of it comes with some mineral oil, you put that on there because it really, really helps visualize. You zoom in a little bit and take your photo, and it has transformed the way we read online consults now. And it helps me keep a lot of my patients at home that don't necessarily need to come in, because like a far out photo, a lot of things look like melanomas, but when you can get that close-up dermoscopy photo, it's really, really helpful.
Yeah. Thoughts about imiquimod for Lenigo malignant? What data they might need, that's a very challenging question to answer. The FDA approval is a long and complicated process with multiple levels of evaluation, and it's not something, for multiple reasons, it's not something that people outside the FDA get a lot of direct insight into the discussions that happen there. I think for a host of reasons, but I don't feel like I have a good handle on when they might approve that. That said, sometimes people do things off label, and that is sometimes done. I don't personally feel comfortable using imiquimod for laryngomalignant malignant. The vast majority. I mean, I would prefer that to not treating, I guess, but in general, I don't do it.
I mean, it's hard, and we've had this discussion before that like it's always that risk benefit analysis, and we have things that are standard of care. But I think as we get more sophisticated technology, so if you can monitor these things with confocal microscopy or things like that, and really prove that there is no invasive component developing within that field, then it's great. I think imiquimod is a wonderful option for like melanoma in situ that's very large and basically deemed unresectable, because these the standard of care is subjecting people to very, very large operations, because by definition, this melanoma in situ spreads quite far. And so it can be quite a large operation. And so I think that, as we get more sophisticated technology, maybe this standard will change a little bit, I hope.
Yeah. I mean, well, I guess we were talking about that in this room. I was gonna say that is the kind of thing that I would discuss at a tumor board, because it's something we could conceivably do, but I would want advice from multiple providers before pursuing something like that.
Freezing a spot.
Yeah, we can. So there's a question that's, what does freezing a spot rather than removing or testing do for the patient? And that it sort of depends what we're freezing and why we're freezing it. But the most common things that we freeze are things that are, we think, a precursor to a squamous cell skin cancer called an actinic keratosis. We freeze those because we think that we are going to clear that lesion without having to remove it. And those lesions, when they do not resolve with cryotherapy, become something that we then do remove. And so we're trying to clear those without giving them a chance to either become skin cancer, or without giving somebody 10 to 15 biopsies per visit, which is sometimes how many things we have to freeze.
It's a blunt instrument for wiping things out. Just as a note, we try not to freeze anything that's pigmented unless we're absolutely certain that it's a pigmented actinic keratosis, and those have certain features in clinic.
Yeah, we wouldn't typically freeze a melanoma.
I have a follow-up for that from Facebook. Do all precancerous spots have to be removed?
That's a loaded question. So the answer to that question, really, I would say would be yes, if we know they're precancerous. The problem is that, like, what we typically call a precancer is a lesion that turns into skin cancer at a fairly low rate. So do they all have to be removed? Probably not, but I would never advise somebody not to do anything about them. Typically, I will either freeze them or advise them to use a field therapy that's intended to treat a bunch of them at the same time. If they really refuse to do that, then monitoring them is what I would do next. But personally, I would treat my own, and I would advise people to treat theirs.
I mean, it's hard, and I'm more of a meet people where they are type of physician. And so we have this discussion because some people are like, I don't want mine frozen. Can we just watch this? And it's a 1 in 200 to 1 in 1,000 chance per lesion that one of these will actually, and we're talking about actinic keratoses transforming into squamous cells. Like my preference is to treat them when we find them. If your immune system's intact, it can often come up and clean up some of those cells and repair itself, but not always. And so we try to err on the side of being proactive, because I'd rather do freezing or topical therapy rather than biopsies and surgery. And so that's sort of where we're coming from.
Yeah, and that, I mean, also it sort of depends a lot on the situation. And when I say if people refuse, I don't mean that I'm like trying to strong arm them into doing it. If somebody says no, that's sufficient. But also I'm a big fan of field therapy. I'm more likely to freeze 3 or 4 things than I am to freeze 15. If somebody has that many things and we're needing to freeze a lot, then I'm very likely to suggest that we use something like imiquimod or 5-fluorouracil or a photodynamic therapy option to treat all of those things, so they don't have to keep getting things frozen with regularity. It's a lot of clinical questions.
Yeah, I'm learning, guys, so this is good for me too. Sorry, guys, we're scrolling. Do you want to read this one out loud?
Okay. I have seen that there are many apps and clip-on cameras that claim to have mole mapping and specialized cameras to detect skin cancer. Are there any that you specifically recommend? No, I don't usually. I think that it is, in general, a really good idea to be aware of the things that are on your skin. And if you're using anything at all, even if it's just like a note card to keep track of your moles, and that enables you to notice ones that are changing over time, then that's very helpful. So anything that you're using to maintain your own awareness of your skin, I think is a positive thing. But I don't advocate for any particular product in that field.
Yeah, we did a review a couple years ago of that, and this was like 3 to 5 years ago, of the apps and smartphone technology that was on the market, and in general, those apps performed very, very, very poorly. So either they were missing melanomas, or they were recommending that everything come in for biopsy, which doesn't help anybody.
Right.
And so the field's not there. That's not to say it won't be there, and we're always monitoring. I know that our dermatologists who've developed the Split smartphone camera device are working on some AI technology for their device. So, that hopefully will hold some promise, but nothing's perfect.
Yeah, I was just going to say that the studies that I've seen that have looked at AI's ability to detect skin cancers, and that say that there have been headlines of things that were like it performs equivalently to a dermatologist. That's actually not true. And when they say that, it's been in a very, very limited sense. So they'll take like 2 things and say melanoma yes or no, or melanoma A or B, which is not what you're actually asking when you have a spot or 10 spots on your skin. So they sort of softballed the AIs in the studies that I've seen on that. Again, that technology is improving very rapidly. So I'm not saying that will always be the case, but I haven't seen anything that.
Yeah. So not ready for prime time yet. Bottom line.
Yes, so Sansi has said mole mapper is just for tracking change on your own, and change is relevant. That I totally agree with, and that's what I was trying to get at. Yeah, if this is something where you're taking pictures of your own moles, or you're keeping an eye on them, yeah, I'm very much in favor of that.
Yeah, evolution, I think, is one of the most important things. Is when a mole starts to change, that demonstrates that there's something going on.
Do we want to do, what should I be looking for in a sunscreen?
Yeah,
sure. My favorite thing about a sunscreen is that you like it, because SPF 50 is better than less than SPF 50, but the most important thing is that you put it on with regularity, and that you're not going, oh goodness, I have to do this again. Because I want you to put on sunscreen anytime you're going to be exposed to UV light, which is most of the time you're either outdoors or near a window, which is to say pretty much every day. And I want you to do it every 2 hours while you're actually outside. And if you don't like doing it, you're not gonna.
Mm-hmm. Yeah, I mean, it's really important to like have something that feels okay to put on your skin, so that you'll put it on with the frequency that you want to put it on. So the best type of sunscreen is the sunscreen that you'll use. I mean, we have the general specifications of, at least SPF 30. If you're worried about chemical sunscreens, go with the mineral zinc oxide or titanium dioxide ones. But really, it's just try them out, and it does not have to be expensive to be
That's
good.
very true. Yes, the non-branded things are often just as good or better than the things that are quite expensive.
I was listening to one of my patients gripe on the phone yesterday about he loved the Trader Joe's sunscreen, and they just continued. And he's like, I think there's some conspiracy. I think it was too cheap. So anyway, but yeah, use the sunscreen.
Yeah. Also, I just wanted to say, because you've mentioned a couple of times about how the FDA studies the actual SPF of a sunscreen, the amount that you're supposed to use to treat yourself, you get like 3 or 4 applications out of a bottle of sunscreen to your whole body.
So please find one that's
tremendous
affordable.
amount.
It's the little bottles of sunscreen that are like $50, not useful for anybody. Because you have to apply so much, and then that's why I gave my spiel about UV protected clothing. It doesn't wash off, doesn't wear off, and as long as you've got like something that's UPF 30 or 50, that should be good. And then you use the sunscreen for whatever you can't put clothing on. It looks like we've got another group. Are we in time?
I'm sorry.
Thank you, guys.
Thanks, everybody.
Off we go.
I'm sorry. Come in. Let me introduce real quickly. Hello, viewers. We have our surgery group coming in now, so please start loading in your questions. We have quite a few already, and I'll show you. Come on in. You're going to have to be close. You'll see here that we've been trying.
Front seats.
We've been dismissing them as our first two groups, oncology and the dermatologist. So you just roll through these and find the ones that apply to you. And if you'll just read them out and then answer away.
Okay, great. Thank you.
Thank you. And in the meantime, there may be some questions that come in from Facebook, which I will shout out to you, okay?
Okay.
That's
good.
So there's a Mohs question.
Oh, yeah.
Dr. Yu,
What factors do you consider when deciding to do Mohs surgery? Okay. Well, so there are a couple of factors. I mean, I think the most important are number one, anatomic location. So where that melanoma is. If it's on the head and neck or in a sensitive zone, then that might be an indication to do Mohs surgery. And then the second is what stage the melanoma is at. So if it's an early melanoma where it's all contained in one spot, then that might be a place that we could do Mohs surgery. If it's, so actually in the other room, we talked about an analogy that melanomas can be sort of like a cookie. Some of them are crumbly, some of them are going to stick together. The ones that are that stay together are the ones that we can do Mohs on. The ones that have crumbled already and that are potentially sending out little cells in different directions, that's a case where you'd want to do a wide local excision and get some margin around it.
Great.
That's a great question.
There is a question about, are there still circumstances when the patient should have all their lymph nodes removed, or is that no longer necessary? So as part of the two-part operation typical for melanoma, wide local excision and sentinel lymph node biopsy, well, before a major trial from approximately 10 years ago called the MSLT2 trial, routinely, if there was a sentinel lymph node positive results, you would go and do a completion lymph node dissection. But that trial found there's no difference in long-term survival. So the norm now is not to do that, even if you have a positive sentinel lymph node. The exception to that is if you have bulky disease in the nodes on presentation, or if you have recurrence of clinically positive, meaning you have palpable lymph nodes indicating bulky disease, significant disease, then you're supposed to go in and do the completion or therapeutic lymph node dissection. There are caveats to that, but that's the general concept.
Next, let's talk about the danger of melanoma, squamous basal cell. All need to be surgically removed? Question mark. It's a great question. And I think that it does depend a little bit on the nature of the skin cancer. Sometimes there are superficial skin cancers, like a superficial basal cell carcinoma or a squamous cell carcinoma in situ, which means that it's only in the topmost layer of the epidermis. And in those cases, sometimes you can actually treat with a chemotherapy cream. Sometimes you can also do kind of what we call an electrodesiccation and curettage, where we kind of burn and scrape the tumor. Or sometimes surgery is the best option. So it kind of depends on kind of how thick it is, what kind of skin cancer it is, whether it's a low-grade skin cancer like a basal cell carcinoma or a melanoma, in which case it's a much higher grade, so needs surgical treatment most of the time. So it depends on kind of the case. Let's see.
Okay. Yeah. From an anonymous attendee, are there any surgical trials other than Dr. Yu's that OHSU is working on? Oh, yes. Yes, there are lots of trials. It's a good question, and thank you for asking it. Actually, my trial is not open yet. We're working on getting funding for it and getting patient advocacy for it. So if you're interested in that, please do let us know. Dr. Valenzuela, I think you're involved in some trials, right? Some other surgical trials and also advanced melanoma trials, right?
So I'm not directly involved in them, but as by working here, our patients are enrolled whenever appropriate. I'm directly involved in contributing some patients to Dr. Raj Kulkarni's lab and his studies for basic science, in which he's studying well, two things: the effects of immunotherapy and derm side effects, rashes. So for patients who enroll, we can contribute some skin at the operative time. And if the patient ends up receiving immunotherapy at a later date, then, and if the patient gets a rash related to the immunotherapy, then you can compare the same patient's skin after and before and get some information about that process. So that's the primary project that I'm involved with directly. So.
I think, are you on the design track?
No. Okay. Yeah. Let's see. Are there any studies discussing the safety of utilizing UV or LED gel nail dryers at the nail salons? Oh, that'd be very suited. I mean, LED just sounds safer than UV.
Yeah.
But not familiar with the literature.
Yeah, large scale studies that I'm familiar with. I will say that these UV devices at nail salons are not regulated at all. So they're not FDA approved devices. There's very little regulation in the wavelength of the UV light that is used. So I do tell my patients who get a lot of nail treatments to be mindful of that.
Yeah, and we do see there have been reports of HPV infection from treatments in nail salons, which then can lead to squamous cell carcinoma. So there's squamous cell carcinoma of the nail unit, which can be dangerous. And that is something that to be aware of as well.
That's a really good point.
There's an Ipi-Nivo question crossing the blood-brain barrier. I think Amy Cohn may be more. Is her group coming in next?
They came in, but we have a treatment group coming.
Okay,
So
they might be better suited to answer that question. Start seeing melanoma, is it? Yeah.
I think that's more melanoma.
Yeah.
Yeah. All right. Oh, Mole Mapper is available on the iPhone. I've heard some people are having difficulty downloading it or finding it in the Android store. But at least for the iPhone, I have it on my phone. I recommend it to everyone to use and track your own moles. I think it's a fantastic program. Sansi deserves a lot of credit for getting that produced and distributed. It's fantastic. It even names your moles. It gets, so I think it's a nice feature. So.
okay, I had something I'd written down before I came, and so I will. It says this one that came in earlier said, "What about surgery in the setting of a stage 4 resectable melanoma?"
Stage 4 with what's called oligometastases, or very few metastatic lesions, limited, that also happen to be resectable, meaning in locations that the operation has an acceptable risk. Then you actually can operate on those. That's in the guidelines. That's a case-by-case type of individualized decision. What's better, going after surgically and exposing the patient to potential risks of an operation? If it's, let's say, one brain met, is it worth going after, or is it better to radiate? It's not an easy decision to make. Or is it worth continuing with immunotherapy in those settings? That's all individualized, and those are all acceptable options.
That's all the questions that I have. Is there anything else on here?
I think, not right now. Any other written questions?
No, that's it. I have some that I think, I have some that I think are, here's some that you might feel comfortable. What do you consider the best way to know if you are getting the correct post-cancer treatment? Is that for this group?
Well, we always, at least after surgery, we always say that that person should continue to follow up with their general dermatologist. It's important to get the right follow-up, particularly for patients who have had a history of melanoma, basal cell carcinoma, squamous cell carcinoma, because the chances that you will get another one are quite high in the years that after you've had treatment for one of them. So I think in one study, in the 2 years following treatment, there's about a 50% risk of getting another skin cancer if you've already had one. And so it's important to get those caught as early as possible. so that you have all the treatment options available to you, and the treatment is as easy as can be.
And my 2 cents on that is, well, there's fantastic surgeons and medical oncologists in the community. But if it's always a good idea, if you have a cancer of any sort, to have a second opinion at a NCI or nationally designated cancer center, in order to make sure that all of the available treatments are being offered to you and that you're on the right track. It's never a bad idea to get a second opinion at an NCI designated cancer center.
And there's a question for you in the chat. Can you guys get look in the chat? Not in the Q&A.
TILs, yeah.
Oh, in the chat. So TIL therapy probably is better for Dr. Cohn. Let's see. I don't see other questions in the queue.
I think that's refers to the TILs.
Okay.
So yeah, whenever you have
The freezing response. I don't know if this question was answered. Was this question answered? What does freezing a spot rather than removing or testing do for a patient?
I see.
I think that's a really interesting question.
Yeah.
So cryotherapy is something that we do for a lot of things like actinic keratoses, which are kind of precancerous lesions that can develop into squamous cell carcinomas. I would not recommend freezing a mole. So if it's like a mole or a pigmented lesion that could be a melanoma, I would not recommend doing cryotherapy, because sometimes what happens is that cryotherapy gets rid of the pigment. So it looks like it went away, but it did not. And then it can come back, and it can actually sometimes cause a delay in diagnosis. So I think it's really important to get the right care for each lesion. So there are some things, as a dermatologist said, I would treat with liquid nitrogen and it works very well. And then some things that I would biopsy.
yeah, and don't freeze dark moles. That's not what it's for. And and then you can have it disappear and then present 5 years down the line with metastatic melanoma, and you missed an opportunity. So how the TILs therapy work, I'm not directly involved in TILs, but as a general concept, melanoma, one of the few favorable characteristics it does have in humans is that you have a natural immune response against melanoma that occurs in many patients, even without treatment, which is why when our dermatopathologists take a look at these biopsies, one of the characteristics they report is tumor infiltrating lymphocytes, whether they are present in your melanoma or not. And if they're present, how brisk or how active they look. TILs therapy, you take that biopsy. This is my understanding, although I don't do it directly. You take that biopsy, you isolate those cells while they're still alive, you grow them in the lab and multiply them, and then you inject them back into the patient, because theoretically they're already been training to attack that melanoma. And then theoretically, that would allow these cells to attack any other spots or oligometastases or lesions in your body. That is an area of active research. So there are clinical trials going on nationally on that.
Okay, I think it's time to switch. And you're supposed to go to 4, is that right? Is that the only space that you haven't been to? Okay.
This is one.
Yes.
Right.
Thank you.
Have a good day, folks.
This is a test in our ability to learn new things, right? Thank you. Thank you, guys. Okay, thank you for sticking with us. Our last group is going to come in and talk about research and treatment. And so if you'll continue to put your questions in, we still have quite a few that haven't been answered, and we should be getting started here in just a minute. Thank you. Here they are. I'm just gonna come have a seat. You have to switch. I hope everybody took a shower this morning. Okay, our treatment and research group is here and I have 3 questions on cards and you have questions waiting for you, okay? So come, and this is our live group. We have about 20 people online live.
Okay, we can just.
So actually your biggest breakout group is right here.
Yeah.
Okay, so you'll just read the questions here and then decide who wants to answer them. And then if any of these seems like a natural follow-up to that question, I'll read them out. Otherwise, I'll just give you these 3 at the end. I'll save them, okay? Okay, right ahead.
All right. Well, I'm Jake for anyone who didn't see the earlier section.
I'm Elena. I think there's already a question there, but I'll get to it after you introduce yourself.
And I'm Gina, part of the high school program.
All right, start from the top.
Start from the top.
All right. And I guess just to preface, we're all medical students and early graduates. We're not board certified dermatologists yet. So
Yes.
just so you're aware. So I'll read the first one. In checking out the startseeingmelanoma.com site, it mentions a melanoma outreach screening unit. Are you able to comment on the success and use of this device? So I think you're talking about the SCLIP device. Is that right? Do they have audio like
They do, but they can't respond to you. But just go ahead and make any comments that you want to.
Sure.
Okay.
So there's a lot going on right now with the SCLIP device. And it's, for those of you who don't know, it's a dermatoscope or kind of a magnifying glass that you can put on your smartphone and take pictures of pigmented lesions. And it's opened up a lot of opportunities for people who wouldn't normally be able to come into the dermatologist's office. So it's increasing access to care, and it's a really excellent thing, I think. So I'm really excited to see where it goes from here. I don't know if you all have anything to add to that.
I'm happy to comment a little bit on our melanoma outreach and like mobile screenings. Over the past year, we've been traveling through different spots across Oregon, particularly focusing on dermatologically underserved populations. And over the past year, we provided around 300 skin screenings and just try to find concerning lesions and letting people know, dermatologists, that they can visit nearby and make sure that we're working with the Night Cancer Institute and dermatologists nearby to make sure that they can get those lesions followed up. So that's something we've been doing as well.
Let's see.
Next question.
Is there one above that?
Okay.
I guess we'll go with that one.
Like the last one?
They should have dismissed them as they were answering.
Okay.
So if you see ones that are related to oncology, you see them.
I see.
If
Okay.
they're related to dermatology.
Yeah.
Then.
Is it NCI site?
I'm not sure what an NCI site is.
National Cancer Institute, but I think that might also be related to the
Okay.
oncology questions. I think that's all the questions that we
have
can
there,
answer.
yeah.
Okay.
I see.
Okay. Oh, I'm interested in the mobile unit device in the van. Do you have any information on that?
They will need to repeat the question.
Yes. Oh,
Yes.
Okay.
Yes.
I was just asking because
So
I don't know the
here-
answer to that question. If
Go ahead.
someone else has.
Well, so it says, I'm interested in the mobile unit device in the van primarily. So the van that we've been traveling with has been the Night Cancer Institute van. So it's primarily run through them, and that's the one we've been using. I'm not sure, how else I can help you answer that question. Do you have an event that you're hoping that the van comes and provides skin screenings? Is that what the question
You
is?
said you're interested in what happens there and, you know, what kind of preventative care is provided at those events.
Oh, okay. So yeah, those events usually, we'll have a dermatologist come with us. Dr. Leachman has been to all of these events, and we'll have participants fill out a form. where they talk a little bit about their past skin history, their family history, and when available and when they have a concerning mole that they'd like to get checked out, we can use the van as a clinic space and provide a skin screening with a board certified dermatologist, that is Dr. Leachman. So, yes.
Dr. Leachman's on.
Yeah,
good.
Yeah, I'm Dr. Leachman.
I have one that says if taking Braftovi and Mectovi, does sugar need to be completely avoided? That.
That seems like a dermatologist doctor question.
Oh, okay,
Yeah,
all right.
yeah.
And then you said you had some
Other
questions on the note card?
Well, that's what,
Oh, those
so
are-
this is what I thought. I thought that we would be talking about science during this section.
Oh, okay.
And so maybe there are things like that. Is Nevo preferred over Ipi-Nevo, if you're BRAF positive, those
Okay, I
kinds
think
of
this is more for the basic science group.
Yeah.
Yeah, or like public health.
Yeah.
Group,
I wish I had more oncology.
Training, but
therapy
not yet.
training.
No, yeah. Oh, we got our next question? Do you want to go for that one?
I'll look.
Oh,
So you- I
I
think
can
this
take
is a
that
Jake-
one.
Oh, okay, good,
You have
good.
Questions on public health, is that correct?
Yeah,
That's my
start
area.
looking.
Yeah.
So this question is asking, can you describe the work with hairdressers? And so I went over it really briefly earlier, so I'd love to talk about it a little bit more. So every time you get your hair cut or see your hairdresser, they see your skin on your face, on your scalp, and on your neck. And that is an opportunity for them to see something that you might not have seen as far as a melanoma. And so the idea behind this work that we're doing with this group is we call them the Skin Crew. And we have this, we partnered with Impact Melanoma, which is a group on the East Coast. And they put together this training to help hairdressers and the Skin Crew members to be able to identify melanoma and suggest that their clients should go see a doctor to get it checked. So what we've done here in Oregon is we reached out to every single every possible member of the Skin Crew that we could find, basically every hairdresser, barber, esthetician, massage therapist, anybody who sees skin on their clients, and invited them to take the training. And we've seen a really enthusiastic response with people taking this training. And part of it is they take a pre-survey and a post-survey, and we compare the ability to identify potentially bad lesions or bad melanomas or skin cancers. And we compare that pre and post training. And we've seen that they are able to do it better after the training. So we know that the training is effective.
Okay, so follow up to that from Facebook. Can you talk about the work you are doing with other professionals?
Yeah, so I guess as far as other professionals that are within the Skin Crew, kind of it's a similar program with inviting people to take this training course. And
Yeah, there's like
There's
massage
tattoo artists,
therapists. Yeah, there's all
Yeah.
sorts of like, so it's not just hairdressers, there's, cosmetologists, like people who are doing nails, there are people who, tattoos, all sorts of stuff.
yeah, there's a wide variety of other licensed professionals.
And then what are you doing with the information that you're collecting?
Good question. So that's part of my job. I am the main thing that we're trying to do is get everything written up into a manuscript so that people can see how the benefit of what we've done, and then do it in their state or their area. So we're just comparing that pre and post survey data to show the efficacy of the training. And then we're also, we also use some of the data to send out more resources and more training to the people who are interested as well.
Okay, another question. And do you have any hints, or can you give us any, a little pre-information about what you're learning?
Oh, yeah.
Any of that?
Yeah, sure. So I'm kind of, I'm still in the process of analyzing most of the big set of data, but we did see that that estheticians, specifically as just that group of professionals, they were able to identify melanomas and other types of skin cancers fairly well after the training. And there's also a large group of students of cosmetology that took the training as well. And so it's going to be really interesting to see the next set of follow-up data that we get from those respondents too.
Okay, well, thank you. And they need you back in the other room again for the general question and answer session.
Sure.
And I'm going to bring my live crew back in.
Okay. Thank you so much for
online.
the questions.
Well, thank you. Okay, we're going back into the general session.
It's because. On with a very quick panel Q&A session for any additional questions. Oh, beautiful. I just needed to start talking. Okay, so I just wanted to open the floor for a very quick additional expert panel Q&A. So it's kind of anything goes. Just go ahead and raise your hand and we can get to any questions you didn't have. This is only going to be a little bit over 5 minutes because of the awesome conversations you're having. I know we're running a little behind, so if you need to go, please feel free to do that. Otherwise, we're going to answer some more questions.
Got a quick one about clothing, and not specifically SPF clothing, but regular clothing, and what kind of sun protection you get from.
Yeah, so the most sun protected clothing is probably actually denim. Because if you think about it, it's tightly woven, it's dark in color, it's a thick fabric. So the general rule of thumb, if you're gonna go for something that you wanna wear all summer and you need something lightweight and breathable, I'd look for the specific ultraviolet protection factor clothing, the UPF. And so it's roughly equivalent to the SPF you see on sunscreen, and it comes in 30 and 50. Now, just about all clothing is sun protective, right? Because, you know, how many of us have actually gotten burned through our clothes? It's pretty rare. It generally happens with a sort of lightweight white cotton t-shirt. So general rules of thumb are something that's tighter weave, darker, the like athletic wear fiber, you know, the kind of like swift wick type of, you know, dry fit stuff tends to be more sun protective than the lighter weight cotton things. And so you want something that's just tightly woven, darker in color. So you can wear your jean jacket and your blue jeans all summer long if you want.
In the back here.
Has there been any research or any information about why most skin cancers, melanomas are on the face, and why it seems to me that's where you get the most sun, yet that's not where the melanomas, at least on me, occur?
That's what I'm
It's a good question. I don't know.
There's something about melanoma that's a sort of intermittent sun exposure problem. So there are, you know, certain subtypes of melanoma that come up more often in chronically sun exposed areas. But as you've noticed, you know, the highest risk for a man is for melanomas to come up on the back. Highest risk area for a woman is on the legs, and those are areas that you don't think about getting a whole lot of sun. And so there's something unique about melanoma that I think really requires those like one-hit blistering sunburn type of encounters that are really severely damaging to the DNA, as opposed to the kind of like chronic low-level sun exposure that you get kind of on areas that are always exposed.
And as you mentioned, not all melanomas are necessarily UV induced. So, you know, you have some melanomas that are related to UV DNA damage, but some melanomas are not. So it also depends.
Yeah, melanoma is one of the most highly mutated cancers, and so it takes a lot of different mutations, and whether, you know, sun exposure is what kicks that off, or having like a big birthmark and a lot of melanocytes there is what kicks that off. There are a lot of different ways to get to melanoma.
I think one of the biggest concerns would be if somebody's not coming into, let's say, OHSU, and they're going to a small hospital, and it is the pathology getting diagnosed correctly? And then if they do get referred into you guys, do you redo the whole pathology at OHSU?
That's a great question. So the cases or patients who are referred to surgical oncology here, like Dr. Venezuela, so we review all the cases from the outside lab. So we get them mailed in, and we also reviewed, the radiologist reviewed the imaging, the dermatopathologist reviewed the pathology. So we do review that data all together, and then we can discuss it at our tumor board.
Going once?
The title of the conference is The War Against Melanoma. I already asked you the question, so you can't answer. Do you think you are winning, and do you think you can reduce melanoma to the same status as smallpox? The greatest achievement in science, right, or medical science.
Well, aren't they coming out with an inoculated shot, wait a minute, you know, a vaccine that they're working on? I mean, I'm curious.
That's where I'm going with the question.
I think that's a great question. Do we want to go down the line and just say the biggest wins we think about in our field? You want to start, Dr. Hornick, to put you on the spot?
Don't put me on the spot or anything. But yeah, no, I mean, I think that certainly we've made a lot of progress recently. I mean, I think melanoma treatments, there are a lot more options and a lot more successful options than there were even like 10 or 15 years ago. It's a very different disease. In terms of whether we will completely eliminate it, that I think we can aim for rare. I think it would be surprising if we absolutely eliminated 100% the way we did with smallpox, but, you know, I would love to see it.
So I'm on the research side of things, and I think biasly, since I study immunotherapy really changed the game with advanced melanoma, and researchers are continuing to better understand how the immune response works in the context of cancer. It's not the same as infection, but we're learning a lot from things like vaccines in infectious disease. And so I firmly believe that we will continue to chip away at this patient population that's not responsive to the current therapies that we have. We're discovering new targets all the time and learning how to appropriately pair those together to get response. So I guess, you know, are we gonna eradicate it? Maybe not eradicate it, but I am confident that we'll continue to develop better ways to treat it and ways that are less impactful on quality of life, which is, I think, a really good goal.
So my opinion is, and it's very audacious to say, but I think we can eradicate death due to melanoma. If everybody in the population had the same understanding and screening practices that you all have, I think we would catch melanoma early every time and no one would die from it. But that's a very lofty goal and we're working towards it, but you know, it's what we want to do.
Okay, and I guess I would say in terms of reaching adolescents and reaching people younger and trying to both prevent melanoma and have younger people learn about early detection of melanoma, I think we're making great strides. I hope that our program reaches everyone, not just in the state of Oregon, but across the United States and elsewhere. And I think once we start having this greater education, it will definitely reduce the incidence of later stage melanoma, catching it later, and then also preventing these sunburns and stuff. So I think right now we're doing an excellent job, and I hope that we are able to do to decrease the overall amount of melanomas that are coming up and coming up late stage. But yeah, that's kind of where I'm at.
Yeah, so for me, I think we're doing a great job with melanoma overall. Particularly, I think a lot about not sun-induced melanoma or UV-induced melanoma. I think most of our educational materials, I'm thinking of public outreach, is very much geared towards A, B, C, D, E's of melanomas and your typical sun UV-induced melanoma. So I think from that sense, we can definitely do a lot more education towards non-white skin. So that's something that we're working towards and definitely
Overall amount of melanoma.
Just increase awareness in skin of color population that we are not immune from melanoma, and that melanoma is very much still a reality, even though less likely, it is a reality. So just bringing that awareness, I think it's an ongoing work that we're doing. Yeah.
Everyone said really good points. I don't have much to add, but I think that we definitely made great strides. In terms of, as a dermatopathologist, there's kind of two goals that I have is accurate early diagnosis, but also, knowing when it's not melanoma. So kind of more precision diagnosis. So I think it's both aspects that we are working on, and there's a lot of new tests and, like next generation DNA sequencing. Sometimes gene expression profiling tests can also help with, knowing the prognosis of melanomas. So all these tools help us make more accurate diagnoses earlier. So I think that we're definitely getting there.
So just the past 12 years have marked a watershed for melanoma therapy. And it's only been in the past 2 to 3 years that we've actually seen a decrease in the deaths from melanoma and actually a decrease in the incidence of melanoma in people under the age of 50, which is saying a lot. Now, there are a lot of factors at play, but I think going from the primary prevention and understanding your sun exposure risk and also these revolutionary immunotherapy and targeted therapies, we're finally seeing the needle move. And for me as a researcher who's been in the field for a really long time, it's really refreshing to see. And then Anne just asked me to speak to a question online. Somebody asked if OHSU was one of the only NCI designated cancer centers in Oregon, and I believe it is. I think we're the only, healthcare system with an NCI designation. So total non sequitur, but on to you, Reed.
Still an important point. It's a really good one today. I'm a kind of an rather under-promise and over-deliver person than a vice versa. So I definitely, realistically, I don't think it's eradication is at all the goal here, nor should it be. I think that's unrealistic. But I do think that, especially in the patients I see from a radiology perspective, we're trying to move the needle in collaboration with a lot of other clinical partners and all the emerging pieces of the puzzle to convert this ideally more to a chronic condition than a death sentence, right? We have ways to go still. But I think that we can really reduce that to some measurable, significant percent. What that is, set your own goals, and I think you can put this out there as cancer moonshot goals, right? Reduce 50% right by, whatever year it is, but that kind of thing. I think we're on the right path.
I had another question, but I'm going to wait till you get down to the end of it.
So I also would echo what everyone else said. I think that one thing that's important to remember is that the evolution and progress of cutaneous melanoma versus mucosal and ocular melanoma are different. So in that sense, I would say we're probably a long way from eradicating. But I think that if I look back to when I started practicing to now, there have been so many game changers that make this a much more hopeful field compared to when I started. That I think we've won many battles, but many battles to go.
Yep, so definitely echo that as well, especially someone in the world of ocular melanoma, because even with congenital melanoma, which is similar to cutaneous, that incidence is still increasing actually. And so, when you look at that, it doesn't feel quite as hopeful, but on the other hand, we're doing a lot more interacting with our colleagues, along the line in terms of treatment. So I think just treating it to be a disease that people live with rather than, again, a death sentence is really moving in that direction. And I think this is actually a great example of all the ways it's being approached, from outreach, prevention, and just multiple forms of treatment. And that's why we all feel hopeful, even in the setting of some melanoma still increasing in number.
A question I forgot to ask the education folks and the focus when you go out to train new doctors about melanoma. I have a friend who just was diagnosed with a very rare version of melanoma, which is in her anus. And you talked about how some melanomas are found inside of your body, that the only way to find them is if somebody is going in there and looking. So are you actually working at all to educate those folks who are doing the colonoscopies of everybody who's turning 50 and trying to help make sure that they're well educated on that? Or is that already part of their curriculum and they're already well aware?
I believe it's already part of their curriculum, but you're right. I mean, it's just part of my passion is going out and training primary care physicians on how to identify melanomas early. And we've got all these prongs, but getting to the GI doctors is definitely one area that we could
beyond
use as a future direction.
For the anal piece, though, a lot of that's accessible beyond colonoscopy. It's simply an office procedure is colonoscopy. It's not the most comfortable thing to do fundamentally, but it's very doable. The problem is we're not doing endoscopies on the entire population. That's really, the number that you're going to catch for the relative pain inflicted upon the population is probably not worth it, even though for that one individual it is, right? But for certain high-risk populations, it's definitely a screening tool that can be used, and that can be done in a primary care office, frankly.
Yeah, well, it seems that anyone 50 or older is supposed to get their first colonoscopy, so you've kind of covered the population. I'm not sure you would expect people under age 50 to go get colonoscopies, obviously, unless they have some other history of melanoma that you think it's worth them doing it. But
I'm just going to clarify one thing, putting on the general oncology hat. Screen colonoscopies start at age 45 now, so don't
they do?
And if there's family history, it's age 40.
Oh, really? Okay. Great to know.
Yeah. How do you see the MSEDs in the early detection field, with the Gallery test? and stuff? How do you see that on catching the melanomas that obviously can't be seen with the naked eye?
Oh, you're looking at me.
Like,
so
anyone, you know, I'm familiar with the Pathfinder study and the Gallery test. How do you see those as far as being catching things earlier?
Yeah.
Since you can't be seen.
I met with the PI of the Pathfinder study to see how we could interface, and with melanoma, generally we're finding it on the skin before it's found in the bloodstream. It's a rarer scenario that we can't find a primary, and so far they haven't detected any kind of melanomas of unknown primary in the bloodstream. But where I saw us interfacing was, in my patients with cancer predisposition syndromes, like, is there a better way for us to screen them for other cancers? Because I feel like we're pretty good at skin screening.
Yeah.
Now, it's not perfect.
So I'm referring to the anal where you wouldn't see it unless you wouldn't see it.
It's a great question in the area of future collaboration. Anybody else? Pathfinder.
All right, I'm going to take that as tie a bow on that. I'm going to go ahead and invite Ann up, who is one of our collaborators from AIM at Melanoma, who helped organize this conference.
You guys know me as the doorman, and so I wasn't here when it first started, and so I always like to know, how many people are at a melanoma symposium for the first time today? Anybody? Or most everybody? Okay, and so that means you may not be familiar with AIM at Melanoma, and so I'd like to tell you a little about our origin story, and then how we work together with cancer centers. So, I'm in the middle of here, so I'm sort of in the middle. So AIM at Melanoma was founded 19 years ago when Val Gill's precious daughter, Charlie, died of melanoma at just 26. And she decided at that time that she wanted to form an organization that's purpose would be twofold. One would be, let's find a cure for this disease. And then the other is to support people who are living with melanoma. And of course, fortunately, because of research, there are more and more folks doing that all the time. But what AIM has done over the course of the last 19 years is build a lot of resources that we then have put on our beautiful website. And that's really what I want to do, is tell you about our resources and our website. We believe that well-informed patients are better participants in their care. I hope that our practitioners will agree with that. And so we have developed a website that has information that we believe is relevant, and it is intentionally current, so that you can really count on this information. So if we can go to the next slide.
But.
Oh, we want me to push the button. Great. Okay. So we have a website that's really soup to nuts, and it's filled with all kinds of information about melanoma, no matter where you are in the journey. It starts with, melanoma one-on-one. What are the various stages? How can treatment vary from stage to stage? It also talks to you about side effect management. We know that people who are undergoing treatment need quality of life. And so that way you can learn a little bit about what you might expect as you go through treatment. And also there's information in there about current clinical trials. So I encourage you to go and educate yourself and take advantage of all this great information. But if you don't find your question there, we have a resource for you. We have a program called Talk to a Medical Expert. Melissa Wilson is an oncology PA that works with Dr. John Perkins in Pittsburgh. And there we have a form. You can go in there, write your question. Now, she's not there to alter your plan of care. What she's there to do is to answer questions, something you don't quite understand. What's the next step for you? Why does your pathology report look the way it looks, that kind of thing. So you can try to help you understand some of those clinical questions that you didn't quite get answered when you were visiting with your practitioner. And then as a companion to that, Melissa started making webinars. So for those most frequently asked questions that you get asked through the Talk to a Medical Expert, she's made a series of webinars. I think there's 18 or 20 of them now. And a couple that that she put out there recently is, how to understand your pathology report. And she did one recently on the cancer vaccine. So I encourage you to go and watch this webinar that she just recently put out. Then, after that series had run for a couple of years, we found that there were many questions that people had about all the sort of non-clinical issues related to living with cancer. Things like, will exercise benefit me? What do I do because I'm afraid of the sun now? What about my nutrition? What about the general anxiety that I'm feeling? And so we started a podcast. It's been running for about 2 years now. And Dr. Raymond Liu is our host for that. And we have wonderful guests that come on. And so I encourage you to check out our podcast. They're absolutely fantastic. And the next thing that I want to talk about before I move further down the slide is I want to talk about caregivers. We know that caregivers are involved in treatment, decisions. We know that you need to take care of yourself. So there's a lot of information on our website about caregivers too. We have not forgotten you. And then Peer Connect. We have a peer-to-peer support program. That is, the intention for that is that we know though the folks who are diagnosed with melanoma are surrounded by people who love them and want to take care of them, this still can be an isolating experience. And now the heads go like that. And so we have a program where people who have gone through the treatment journey are willing. We have 50 people from all across the United States that have offered to serve as mentors. And they can offer you some of their sage wisdom, but perhaps more importantly, they can offer you an empathetic ear. They know exactly what you're going through. So if you would like to have a mentor, please get in touch with me, and I would be happy to talk with you and pair you with somebody. And if you are ready to serve as a mentor, if you are on that other side of the journey and you'd be willing to offer that support and encouragement to somebody, I would love to talk to you about that too, because the more the merrier in that program. The very last thing I want to talk about is these symposiums. I've been remiss because I did not start by saying that OHSU has been a partner with AIM at Melanoma for many, many, many years. And normally our president, Sam Gill, would be here. She sends her apologies that she could not be here, but she also sends her appreciation to Dr. Leachman and of course all these fantastic panelists and in general for the work that they do in pushing forward the mission of AIM at Melanoma. So what are we going to do with this symposium? What we will do is we've been broadcasting live. That's what I was typing doing in the back. And we will take these presentations, pare them down, edit them, and put them by topic onto our website. We co-host 10 symposiums a year. And so that's what we do with all of them. So that information is there year-round for people to view anytime that they need. And we're just so happy to be here. And so with that, I'm going to hand it back over to our fearless leader and let Patrick close us out.
I wouldn't do that. They turned my mic off. That's how fearless I am. Very briefly, we do have a couple of other events. First one is a little less tangible. You may have seen something. Last year we started a statewide Check Your Skin Day as an attempt of having a day of activation for people, not just to be aware that they should be checking their skin, but for people to be doing that. So you have a couple of the slips that are intended to give them out to people that you may know to be able to help them remember to do that on that date. On Sunday, May 21st, we are doing our 10th annual Steps Against Melanoma Walk. But this year is the first year we have expanded this walk outside of the Portland area and are hosting 5 walks on the same day in different cities across the state. So in Portland, Bend, Prineville, Astoria, and Corvallis, there's all going to be people walking for melanoma awareness and to raise funds. Our Portland coordinator is Robin Zimmerman in the back here. We would love to have anybody out to walk. It's pretty fun and pretty low key. You can find ways to register to learn more at wearemelanoma.com. And basically, just thank you to everybody. Definitely thank you to our presenters. Get out there with your awareness month materials and just sort of tie a bow on the whole thing. In my opinion, when you answer the question, are we winning the war? I think that a testament to that is to be able to have a room like this and have just at one academic center have all of these experts and such a wide variety of expertise all working towards melanoma. It's kind of hard to feel like you're not at least partially winning the war, just that many people working towards that one place. So I want to thank everybody and let you on to the next day.